I'm Dr. Raj, and a little bit about me. I'm a assistant professor at USC, Go Trojans, and I'm an internal medicine assistant program director and the associate program director for Sleep Medicine Fellowship. And I actually do board review quite a bit. I've been doing it for the last 15 plus years. Actually, my claim to fame is I teach USMLE Step 1, 2, and 3, and I still do that. I love doing that. And I teach internal medicine board review for also 15 years, and I've been loved being part of the med study family. And I also teach subspecialty boards. So this is what I do. I teach. So what are we going to do? We're going to go over pulmonary today. I'm really easygoing if you haven't noticed my demeanor, so please feel easy. Come up to me during our one break and afterwards if you have any questions. It really doesn't bug me. And that's going to be our roadmap for today. And we definitely have plenty of time, so no rush, and we'll get everything all set up for your board exams and whatnot. So we're going to start off with pulmonary function test. A PFT, I kind of think of it like the EKG is to the cardiologist, the PFT is to the pulmonologist. What's a PFT made of? A PFT is made of three main things. It's made of the lung volumes that you can see over here. And when we think about lung volumes, it's talking about measuring all the volumes, including things that contain residual volume, things like getting the total lung capacity. We think about spirometry. When we have spirometry, what are we going to measure is air flow, which you see over here. And what is flow is volume over time. And you've used flow throughout your time here at Med Study, you just haven't realized it. Flow is, by definition, volume over time, like in cardiac output, that's liters per minute. But in pulmonary and spirometry, we use mLs per second. So anytime we use spirometry, we're going to talk about things such as the FEV1, the FVC, then we'll use the ratio. So that's going to be flow. And by far, spirometry is going to be the most common thing that we use in regards to a PFT. That's going to be the most important component. And the last thing that makes up a PFT beyond the lung volumes and spirometry is something called the DLCO. And what does that stand for? Diffusion limited carbon monoxide. And this is going to be talking about, well, how easily does a gas going to diffuse from the alveoli through the interstitium and into that capillary? So we're going to see if there's problems in one of those three areas, the alveoli, interstitium, and the capillary. So when you put all these three things together, all three components equal a pulmonary function test. By far, I don't mean that everyone needs a full PFT. I would probably say the most common thing you're going to order in reality and on board exams is going to be spirometry. It's very simple. And we're going to be looking at airflow. So when we talk about these PFTs, it's going to be the starting point along with the history and physical to figure out, well, what type of lung disease does the patient have? So by far, what's going to be beyond this, someone comes in and says, I have shortness of breath, this beyond exertion. Well, the differential is always going to be the big three. Are you anemic? Is it the heart? Is it the lung? So of course, we all start off there. Once I think it's going to be the lung itself, and I don't know anything about the lung, then I'd probably do a PFT to put them into one of two broad categories. Is it going to be obstructive or is it going to be restrictive? So that's why I made this chart over here. So we'll start off on the obstructive side and say, well, what one PFT parameter defines the disease as obstructive? And if I only had to pick one, that would probably be the ratio. The ratio of what? The FEV1 over the FVC. So when we say that ratio, what's it going to be? Well, it's going to be low, of course. Then how low? Well, we give it numbers. So if you want to define a disease as obstructive in nature, well, it has to be less than 70% of predicted. So up here, I would write down obstructive, less than FEV1, FVC ratio less than 70%. So we could talk about values in pulmonary based upon the total liter value, like TLC is 6 liters, or we talk in terms of percent of predictive. And that's going to be the one we usually use more on board exams. When you talk to me in the hospital, it's percent of predictive, comparing your values to someone your same age, gender, race, and all these things put together. So less than 70% of predictive defines a disease as obstructive. So I put two arrows here to give some idea of, well, what are the two most common examples? And I put it's the COPD, which is going to be emphysema and chronic bronchitis. Obviously, there are other obstructive diseases out there, asthma, bronchiectasis. Definitely, there are some restricted diseases that have obstructive patterns to it, but this is always the classic thing we put here. And whether you're emphysema or chronic bronchitis, your ratio is going to be low, less than 70% predicted. And then I did put a little dividing line right here, and this dividing line is going to be the one PFT parameter that really truly separates someone who has emphysema or chronic bronchitis. And that PFT parameter is what we call the DLCO. And when we talk about the DLCO in emphysema, well, it's going to be low, low, low. And in chronic bronchitis, well, the DLCO tends to be preserved. And people ask me why, is because just based upon the anatomy, when we talk about chronic bronchitis, that's a disease of what? The distal airways or the proximal? Proximal. And so we just don't do gas exchange in our trachea. So the DLCO is going to be what? Normal. So this is how I kind of piece these things out to help figure out what exactly is going on if you have an obstructive disease. Then I move over to restrictive diseases, and by definition, what one PFT parameter has to be abnormal to define it as a restrictive disease? And the answer is the TLC. That stands for total lung capacity. So I write down TLC up here and put TLC arrow down. It's going to be low. You know, how low? Probably less than 80% predicted. And when I think about restricted diseases, when I categorize them, I put them into two broad categories. I put them in intrinsic or extrinsic. So if it's going to be, regardless of where you are over here, the TLC is going to be low. But intrinsic diseases are going to be problems with the lung parenchyma itself, you know. So what would be a classic clinical example of a restrictive intrinsic lung disease? Probably pulmonary fibrosis. That's going to be the classic, you know. But in broad strokes, I'll put stuff like interstitial lung diseases up there. But of course, IPF is going to be the classic thing we think about. Then if you're not intrinsic, you're going to be extrinsic to the lung. So what diseases would be an example where the lungs would be restrictive, but the problem's not in the lung parenchyma itself, the problem's outside of the lung? I think about the big three, kind of like maybe obesity will fit there, like kyphos, scoliosis will fit there. Then I always think about things like neuromuscular diseases. So whether we're talking about CIDP, which is a chronic form of Guillain-Barré, Eaton-Lambert, post-polio, myasthenia gravis, all these things will be kind of like in the extrinsic column because it's not in the lung, it's outside of the lung. So notice how I have a line right here to separate intrinsic and extrinsic diseases. So what one PFT parameter truly separates an intrinsic from extrinsic restrictive lung disease? The answer is the DLCO. And once again, if you, DLCO is diffusion from the alveoli through the interstitium to the capillary. If you have an intrinsic problem, well, what would the DLCO be in something like pulmonary fibrosis? It's going to be low. But if the problem is going to be outside of that lung, like obesity or kyphoscoliosis, then the DLCO would probably be normal. So it would be on the normal side when it's going to be extrinsic. And then if someone were to maybe throw out like a tricky question like, well, are there certain pulmonary diseases that can give you both a restrictive intrinsic and extrinsic type pattern? The answer is sure, why not? And I could think of like some rheumatological diseases that really fit that nicely. And where are some of those rheum diseases that could present with a restrictive intrinsic and extrinsic pattern? I would think like ankylosing spondylitis, you know what I mean? Because they have fibrosis and curvature of the spine. I would think about things like the myositis, dermato and poly, because there's weakness and plus to get like the fibrosis. So these are ways you could think a little bit outside the box. But this is going to be the kind of the dogma of how I think of a pulmonary function test. So I would use this knowledge through all the pulmonary diseases of how we use PFTs. So when we talk about PFTs, you know, one thing I wanted you to realize is that not everyone needs a full PFT. You know, PFTs, I don't know if you actually seen your patients do one. It's really long and painful, and I don't know, patients really don't enjoy it, you know? So if you're wondering who this person is over here, this is my dad. I put him on a PFT, and he actually still is not talking to me. So I don't think it's like someone's like yelling at you, hold your breath, breathe out, you know? Oh my God. So what are you going to do with the values? That's what it looks like. So most of the time, you just need spirometry. You get most of the volumes, most of the capacities and stuff. A PFT gives you TLC, and the hardest part of total lung capacity is always residual volume. So if you think you need it because it's a restrictive disease, sure, order it. But if you're not going to use it, don't order it. Same thing with DLCO. I mean, if you're going to use it because you think there's an abnormality in the lung parenchyma or the vasculature, sure, order it, you know. But if you're not going to use it, remember, a PFT comes with all three things. And of course, anytime we do a challenge test of some kind, we do it in a pulmonary function lab. So these are going to be your lung volumes. I wanted to show this to you. It's in the med study notes and everything. And what it's showing is that in the red, patients taking a breath in and out, That's called your tidal volume. You take a deep breath in, inspiratory reserve volume, take a deep breath out, expiratory reserve volume. And what's the definition of a capacity is going to be 2 or more volumes added together. So if you add your tidal volume, your inspiratory reserve, and expiratory reserve volume, you get the vital capacity. And all these parameters can be forced when they yell at you, blast it out. So it could be an FVC, a forced vital capacity, but it's the same thing as a vital capacity. And if you want to get that TLC that we're talking about over here, well, then you need to actually add your residual volume to your vital capacity. And this is always that pain in the butt to get, and that's why we do a PFT lab. We'll put you in like this box here called plasmathography. Some labs have techniques called helium dilution or nitrogen washout. It really doesn't matter. And we do all these things to get an estimate of residual volume so you can figure out what the total lung capacity is. And once again, you need TLC to define the disease as restrictive. This is going to be a picture of spirometry. So when you do spirometry, you're looking at flow. What type of flow? Expiratory flow, so you're blasting it out. So I always think about spirometry being really, really good for obstructive diseases, because when do you have the obstruction? It's on expiration. So they show 3 different states: normal, restrictive, obstructive. So when I look at normal, patient takes a breath in. At the end of a maximum inspiration, we call that the TLC. Quick breath hold and blast it out. So on the y-axis, you're going to have volume. On the x-axis, you're going to have time. Volume over time means flow. So how much volume can you blast out in 1 second? And most of the PFTs, to have a good spirometry, you need to at least be able to blast out for at least 6 seconds to make it seem good. But let's look at obstructive over here on the far right. So what looks kind of different from normal? Well, TLC is higher. It doesn't necessarily mean you're obstructive because you have a high TLC, but the big thing is look at the flow when they blast it out, is that very little volume is blown out in 1 second, your FEV1, and as they're blowing it out, very little volume per time is being blasted out. So the flow on expiration is very, very, very reduced. And the main reason why TLC is high here is because at the end of your expiration, you can see that this volume over here is your residual volume. You can see how much residual volume you have. That's what adds up to your TLC. High residual volume means the words air trapping. So I look at restrictive, and restrictive, remember, everything parameter-wise is going to be low with the exception of the ratio, but everything you directly measure is going to be low because the lungs are small to begin with. So it's not surprising that TLC is going to be low, which defines it. FEV1 will be low. FVC will be low. And the key thing to remember, everyone, is that your FEV1 in restricted diseases and FVC is low because the lungs are just small. There's no volume. In obstructive diseases, FEV1 and FVC are both low, not because the lungs are small, it's because the residual volume is so high. And that's why an FEV1 and FVC doesn't define a disease as restrictive. It's only the TLC that defines a disease as restrictive. So just showing you these pictures over here. So DLCO, we spoke about that already, but like I said, this is a nice picture over here on the right. This is your alveoli, in between here is your interstitium, and this is going to be your capillary. So they're showing how a gas diffuses from the alveoli through the interstitium and into the capillary. And key thing is that when you give carbon monoxide, well, who actually picks it up? It's going to be hemoglobin. We all know hemoglobin loves carbon monoxide. So what you need to realize is that you always need to correct the DLCO for hemoglobin, meaning that if you're anemic, DLCO will be kind of low. If you're polycythemic or have more blood flow to going to the lungs, the DLCO is going to be high because you're just going to have more binding capacity to hemoglobin. So always correct the DLCO for hemoglobin in general. So love the bottom line point. So anytime I get PFTs, TLC defines a disease as restrictive, it's going to be low. The ratio defines the disease as obstructive, less than 70%. And then, like I said, the DLCO is kind of looking at how a gas, such as oxygen, travels from the alveoli through the parenchyma into the capillary, the bloodstream. So here's a question. A 60-year-old woman is evaluated for a 4-month history of progressive fatigue and dyspnea on exertion. She does not smoke cigarettes, denies chest pain, palpitations, dizziness, or syncope. She has a 12-year history of limited scleroderma. A screening cardiopulmonary evaluation 3 years ago was pretty good. She also has GERDs. That shouldn't surprise anyone. People with scleroderma have lots of GI problems, not to mention esophagus, not to mention bleeding from the stomach, such as GAVE. Raynaud's, not pathognomonic for scleroderma, but we can see it in many, many rheum diseases. So bad, she has ulcers on her fingertips. On meds, she's on a calcium channel blocker. She's on a PPI, and she probably uses this nitro ointment for her Raynaud's. On physical exam, she's a febrile, normotensive, non-tachy, non-tachypnic, and the cardiac exam reveals a loud S2 with some fixed splitting. Of course, those are some buzzwords. The lungs are clear to auscultation. The abdominal exam is unremarkable, and was surprised she has sclerodactyly. You know, they're kind of listing things out in what you guys call that crest syndrome you guys all memorize. And there's pitting scars visible over the fingertips, no peripheral edema. CBC and ESR are normal. EKG shows evidence of right ventricular hypertrophy. They shoot a chest x-ray, and it's clear. PFTs, so this is where we are. FEV1 is 84% predicted. FVC is 82. The ratio is 80. TLC is 85, and the DLCO is 44. Which of the following is the most likely diagnosis? So you guys could take a look at those 4 choices. And here we go. Cool. So when I look at this, I'll say a couple things. Number one is, why did people pick atrial septal defect? Because you saw that fixed splitting, and don't get me wrong, that was one of the distractors. Everyone always thinks fixed splitting is only part of ASD and VSD, and the answer is no. You can see it really bad in people with bad pulmonary hypertension. 2, what would the DLCO be if it really was an ASD or VSD? Would it be high, low, or normal? It'll be high, because when you shunt from what? Left to right most of the time. So more blood flow will go to the right ventricle, to the pulmonary artery, to the vasculature. So more blood flow means more RBCs. RBCs contain what? Hemoglobin. So DLCO would be what? High. So it's not a ASD. Interstitial lung disease, I think that was a great choice, except what part of the vignette says it's not going to be interstitial lung disease? The chest x-ray, right? It's totally what? Normal. So that'd be kind of weird. But don't get me wrong, scleroderma really has ILDs associated with it, NSIP, UIP, just to name 2 of them. But no, it's not going to be B. And why is it not going to be C? It says on the EKG that it shows signs of what? Right ventricular, good. So when I look at these PFTs, it looks like spirometry is normal, the TLC is normal. The only thing is an isolated decrease in the DLCO. And the only thing that could do that is pulmonary hypertension. And do people with scleroderma are predisposed to pulmonary hypertension? Yes or no? Yes. Even if they don't even have the interstitial lung disease, they can get pulmonary hypertension just by having scleroderma. So answer here is going to be D. Excellent job. And that's why I put the PFT summary of common disorders over here. So this is one you can just look over when I'm gone. But we're going to go over asthma, COPD, emphysema, fibrosis. But look at pulmonary hypertension. Usually, the spirometry would be normal. The TLC would be normal. When you get an isolated decrease in DLCO, because in pulmonary hypertension, the intima, the capillaries, gets a little thickened with inflammation. So that's why diffusion of carbon monoxide is decreased as you go through the capillaries. So in the right clinical setting, I would think about pulmonary hypertension. Be sure to get that echo transthoracic. So flow volume loops, whether you like them or not, they come in a spirometry. And when we think about flow volume loops, we're thinking about the shape of the loop. What part of the flow volume is the most important is always the expiratory. So on the y-axis, this is flow. And on the x-axis, this is volume. In a normal individual, you take a breath in. End of a maximum inspiration is TLC. And from TLC, what do? You blast it out. And you're looking at the flow on expiration. When you think about an obstructive disease over here, it's shifted towards the left. Why? This area over here is residual volume. So if you have a high residual volume, it's going to squish everything towards the left. That's why TLC is elevated. And notice on the expiratory part of the loop that the flow is diminished. The volume over time is decreased on expiration, and that's why it's not very high. You don't have a high expiratory flow, you have a low expiratory flow. And notice how it scoops down over here because it really takes a long time and it's difficult to blast things out. Restrictive diseases, just looking at the expiratory part of the curve, is that everything is just small. TLC is low, so that's why it shifts it all the way to the right. So, and there's no problem in blasting it out. Flow is normal. It's just the lung volumes are small, and that's why you can see that restrictive and normal have a very similar slope. It's just a smaller lung to begin with. So flow volume loops, you're really looking at just a shape, and most of the time we're looking at the expiratory part of the loop because that's the most important. So when you have these things on the right, I know they have these in board exams sometimes, where you get these funky shapes where it's flat on the top and flat on the bottom. This is flat on the bottom. This is flat on expiration up here. What do I think about? All of these are what we call upper airway obstruction. And for all extensive purposes, upper airway kind of means somewhere around the trachea, you know what I mean? So when I see that it's going to be flat in the top and the bottom, I call this a fixed upper airway obstruction. If it's flat on the top or the bottom, I use the word variable. So it's a variable upper airway obstruction. So when I think about these three, the easiest one is going to be the first one, where it's flat in the top and the bottom. What would give me a fixed obstruction in the trachea where I can't get air in and out? So we think of things like tracheal stenosis, or we think about something compressing the trachea from the outside, like lymphoma or thyroid cancer or something like that. That's going to be a fixed obstruction. On these two over here, this is a problem getting the air in on inspiration, but no problem getting it out. And the one that jumps to mind over here is probably a vocal cord dysfunction, where someone on inspiration, the cords close, they adduct instead of abducting. So in the right sense, think about someone in a history of anxiety, usually overweight, possibly female, that you think of this on when we think about the vignette. Think about a vocal cord dysfunction, one of the mimickers of asthma that is not asthma. And then over here is usually the tricky one, the last one. Well, what disease state in the upper airway trachea has no problem getting the air in, but when you blast it out, you have trouble on expiration? This one's tracheomalacia. And everyone always asks me, well, what does that mean? So tracheomalacia is a disease of the cartilage, and your trachea definitely contains cartilage. And remember, when you're blowing out on expiration, what happens to your trachea on expiration? It collapses, but it doesn't collapse all the way. That would be bad. But when you destroy the cartilage, you can't keep the airway open. So on expiration, it collapses all the way. And that's why in the right setting, you would see that type of flow volume loop pattern, and we call that tracheomalacia. Risk factors are the same things for stenosis, which are things like repeated intubations and stuff. So 2 quick PFT questions. A 65-year-old male presents with chronic cough, dyspnea, and exertion. And I'm looking at the spirometry. That's all I have here. And the key thing I wanted to point out is when you think about the ratio, you always look at the actual. We don't look at the percent predicted for the ratio. So please take out your red pen and circle the actual. That's what we look at for the ratio. So for FVC, it's 75%. FEV1 is 63%. The ratio is 68%. And they had the post-bronchodilator challenge. And what is defined as a positive bronchial hyperreactivity response is a greater than 12% change, or 200 mLs. And here, look at the change is 25% here and 30% here. So wow, there really was change. So with all these values I just mentioned, here's the question. You could just, which of the following is the patient's most likely diagnosis? Here you go. Cool, and that was really awesome. So when we think about what makes the disease obstructive, the ratio is less than what? 70. And it has reversibility because of the positive bronchodilator response. So I think of all the answers here, this is the only one that kind of pairs up. So excellent, excellent job. How about this one? A 30-year-old female tax accountant with a German Shepherd and a cockatiel develops progressive dyspnea on exertion. So we'll just stop right there. So I got to give you a little pearl for the board exams. Anytime on the boards someone owns a cockatiel, you're screwed. That patient's done, dude. Don't be ordering birds. There's always buzzwords where you know the patient's going to be messed up, like on board exams. Anytime a patient goes to a picnic, you're done. That's HUS right there, man. End the question. So 30-year-old female accountant owns a cockatiel and has dyspnea on exertion. Let's look at the spirometry. The FVC is 39% predicted. The FEV1 is 43. The ratio is normal at 91 because we use the actual. And it looks like residual TLC and DLCR are all low, less than 80. And there was no bronchodilator response. Here's the question. Which of the following flow volume loops would you expect for this patient? Of the ones here, which one seems to be the most, the most? Yeah, and you guys are pretty awesome. I mean, a lot of these, you're looking for the one that's going to be restrictive, right? And that's the big thing. Is it restrictive? Is the flow volume loop going to be small to begin with? And this is a classic restrictive intrinsic lung disease. If I had to give it a name, probably hypersensitivity pneumonitis. That's the one I would think about. Good job. So let's start. Now that we have the basis of pulmonary, which is interpreting a PFT and spirometry, now we could use that information through any pulmonary disease. So let's talk about asthma and COPD. Those are like big time questions on boards. So when you think about asthma, I mean, I put asthma into two broad categories to keep it simple. I put it into allergic and non-allergic. But there's many names for the same thing. So sometimes people call allergic atopic, sometimes people call it extrinsic, but it means the same thing. And remember, allergic asthma is always your default answer for anyone. It's the most common. 90% of all asthma is going to be allergic in nature, extrinsic atopic. And what are going to be the triggers? Well, it's going to be things like pollen and dust mites, pet dander, molds. And it's going to be very important because only in allergic asthma can we talk about these biologics. And that's what you really came here for, right? For me to talk about all these IL-5s and IL-4, 13 inhibitors that are making asthma so difficult. So if you want to use these biologics, you got to have allergic asthma. And we'll talk about how do we define that and how do we diagnose that. The other broad type is non-allergic, known as non-atopic or intrinsic. This is a 10% of asthmatics. Is very, very small. And what triggers these? Things like the exercise-induced, smoke, viruses, perfumes, medications like beta blockers. And I noticed on the bottom I put bronchothermoplasty, which is this barbaric procedure pulmonologists do for people with asthma. And it's really, its niche is going to be in the non-allergic. Because we have so many biologics that we can give for the allergic type, we rarely have to use this procedure that we're going to be talking about in the slide deck. So just if you're wondering why I put bronchoplasty, thermoplasty over there. So because it's a majority of the questions on boards in reality are allergic asthma, I mean, you do have to know some immunology, unfortunately. So I kind of put some really broad questions here just to jog your memory about immunology. So what is the main antigen presenting cell in the lung for an asthmatic? Here you go. This should be fun. Cool. It's like a little, like a step ladder thingy. Cool. So remember, when we look at I put these questions up for one reason. Anytime it's an asthma question and you ask anyone, the default answer for anyone is always mast cell. I don't know why. They always think it's mast cell. But mast cells only do one thing, right, folks? They release what? Histamine and tryptase, right? They don't really present antigen. And when we talk about asthma, remember asthma is a combination of both our innate and our adaptive immune system. And what makes our innate immune system innate is that they're going to be cells that are exposed to what? The environment. And when we talk about the lungs, there are definitely cells in our lungs exposed to environment that help present cell to our immune system. And what cell in our lung, the most abundant cell in my alveoli, presents my antigen to the immune system? It's the macrophage. So macrophages are antigen-presenting cells. Excellent. How about this one? What is the main inflammatory cell in the airways of asthmatics? So this is going to make a big difference because of all these new biologics and helping to differentiate what is COPD and what is asthma. So what is the main inflammatory cell in the airways of asthmatics? Here we go. Great. So when I think about, what's probably one of the target cells when we talk about asthmatics, especially when we talk about biologics and really causing the whole inflammatory cascade, it's the eosinophil. I agree. Extrinsic asthma, allergic asthma really is eosinophil driven when we talk about the inflammatory cells doing the damage. And this is going to be one of the targets of all these new interleukin inhibitors like IL-5 inhibitors and IL-4/13 is to really inhibit those eosinophils from causing all that damage. So good job, everyone. So when we talk about asthma, I gave you the definition. It's definitely a chronic disease. Definitely, it's unlike COPD where there's these noxious particles that are directly damaging. The particles in asthma are sensitizing, meaning that they have to rev up your immune system. And it's usually going to be reversible. And I put some buzzwords here. It's characterized by bronchial hyperreactivity. And that's why we do this bronchodilator challenge to see if you get this robust bronchodilation, or if you get an antigen, it will cause you to bronchoconstrict, Is bronchial hyperreactivity pathognomonic for asthma? Probably not. Many other diseases have it also, but obviously that would be the first thing I think about when I think of getting spirometry and looking for bronchial hyperreactivity. The other characterized by is smooth muscle in the airways, and I noticed I put that bronchial thermoplasty word there again, is because by heating up the airways, that's the whole thing about this barbaric procedure, is that it will prevent that smooth muscle from getting hypertrophied. It prevents remodeling of the smooth muscle. But those are the two things that asthma is associated with, is bronchial hyperreactivity and smooth muscle. How do you diagnose it? Well, number one, it's always, history and physical. If you want to do something subjective. If you want to do things objectively, well, what do you need first? You need this spirometry. I just only need spirometry. Why? I'm looking for that, bronchial hyperreactivity. But is it wrong to order a PFT? The answer is no. Like I just said, it's a very long test. You're probably not going to need DLCO and TLC just to diagnose asthma. You basically just need spirometry. And then I put challenge testing as the third bullet point. And challenge testing is very barbaric. I just don't like doing it. But when you have someone where you can't make a objective diagnosis of asthma based on spirometry because they do not have bronchial hyperreactivity, the next answer on a board question in MixApp in the class is doing a challenge test. I call it barbaric because it's like, well, you could have asthma, I'm not sure, so let me induce it in you, And we give things like methacholine and histamine, and we look for a drop in the FEV1 or FVC of 20% when we do a challenge test. So the problem with challenge testing sometimes, it's really nice if it happens early in the challenge, but sometimes when we're doing all these dilutions, because if you don't bronchospasm in the first dilution, I give you more methacholine, then more. And by the time I give you the last dose, I'm kind of wondering, do you even have asthma, or is it all that methacholine I gave you, So it's tough. And when is methacholine going to be, when is challenge testing usually going to be helpful? Is it going to be helpful when the result is positive or when the result is negative? Any guesses? It's negative because everyone bronchospasms with methacholine. It just depends how much I give you. But if the result is negative, well, it means that your wheezing is probably from everything in the whole world except what? Asthma. So I guess speaking in terms of biostatistics, it has a very high negative predictive value. Very good. Other considerations over here. I wrote down pheno, and there's a picture of me enjoying the pheno. It's kind of a weird picture now. I'm looking at it. But what is a pheno is literally this toy that you put in your mouth, you blow in it, and what happens is that it measures how much nitric oxide is in your airways. And what we know is that when you have lots of eosinophils in the airways, eosinophils make nitric oxide. So it's a nice, simple way to, in the right clinical setting, to help find another puzzle piece that says it possibly could be asthma. What type of asthma? Allergic. And, the American Thoracic Society is now saying, well, maybe this nice, simple test Maybe one day it could replace challenge testing, which is very barbaric, you know? So they do mention exhaled nitric oxide on Mixstep 18 for those who are doing it. So it's good that you circle that once so you know what it is. Asthma diagnosis. The classic, so how does it present? You guys know this. Dyspnea on exertion, cough, 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 some wheezing. And we want to classify how bad it is. Well, it really depends on symptoms, how much you're using your beta-2 agonist, nighttime symptoms. Using parameters like FEV1 by itself is a little frowned upon now because we know it's more than just looking at a spirometry value to say mild, moderate, severe. It's that plus the clinical, plus the history, how they're doing. So I just wanted you to know that. Asthma treatment. So, of course, I didn't write it down there, but lifestyle modifications will always be first. Simple things first, inhaler technique first. All these things have to go first. But when we think about asthma treatment, you always want to ask yourself, is it the acute treatment? Is it chronic? On IM board exams, if you're preparing for that, most of the questions are on chronic management as an outpatient. And what are some of the medications we could use? Well, you know, when we talk about persistent asthma, the cornerstone therapy is always going to be corticosteroids. And it's going to be, in a chronic sense, inhaled corticosteroids. I only give systemic if we're thinking about an exacerbations. If you're stuck on oral steroids for chronic management, that's not a good thing. That's probably an indication to see if you're a candidate for biological therapy. And of course, there's bronchodilators. Take your red pen and pretty much circle beta-2 agonist and anticholinergic. Those are the staples. Everyone should be on the beta-2 agonist, short-acting for sure. If you do a long-acting, of course, we do that after we add inhaled corticosteroids. Anticholinergics are great. There's data for their use in short when someone comes in for an acute exacerbation. I love beta-2 plus anticholinergic. And in the chronic sense, you know, long-acting anticholinergics like tiotropium have data now to show they're non-inferior to a LABA. So you could think about switching to a LAMA if the LABA is not working, but of course LABA would be the staple thing I do first. Methylxanthines, they just too many side effects. We don't use them in reality or on board exams. Adrenergic agonist, I don't know if anyone's even old enough to remember Primatene Mist. I mean, but that actually got re-FDA approved last November. It's back on the shelf at Walgreens. But we don't use that. It's not prescription medication. We don't really use that for boards and reality. Mast cell stabilizers, I mean, it's losing favor in peds and in internal medicine. It's really not used for adults at all. It's not used for an acute attack. So that's not going to be a good answer for board questions. Leukotriene inhibitors, I would know these in the sense that they're oral. You know what I mean? The leukotriene pathway, leukotrienes cause bronchoconstriction, smooth muscle contraction, lots of mucus, so you want to block it. The two ones out there, Montelukast is probably the one we all know and love, Singulair. It's oral, 10 milligrams. And, you know, I think it's, you know who responds to it. There's going to be people who have extrinsic asthma, and they notice a difference. And I see many patients where we just keep them on Singulair, even though they don't have a respond to it. But, you know, you'll know if they respond to Singulair. And it's a leukotriene receptor antagonist. The other one is Ilutin. I rarely use it. It's a synthesis inhibitor. Lots of liver side effects. We don't use it clinically, though it's FDA approved in the United States. So let's do this vignette together. 47-year-old male is evaluated for worsening asthma. Symptoms characterized by frequent daytime wheezing and cough, as well as nocturnal awakening related to asthma 2 to 3 times per week. He has been using his inhaler regularly without adequate relief, and he had not had recent URI infections, sinusitis, or postnasal drip, or new exposures. He has taken an inhaled corticosteroid and inhaled albuterol. On exam, a febrile, normotensive, non-tachy, non-tachypnic. Lung exam reveals bilateral wheezing. Spirometry shows an FEV1 of 70% of predicted. Following an inhaled bronchodilator, you get this really big improvement of 90% of predicted. So in this person who's not really controlling his symptoms well, clearly has asthma, which of the following is the most appropriate next step in management? And those are the choices. Here you go. Awesome. So when I look at a question like this, some of us kind of gander the choices for a second. Always pick something that's non-invasive, simple, doesn't cost anyone any money. That's always going to be the right answer on the board exams. So, of course, the one that I don't think is going to be a good answer is B. In any subspecialty, is the answer adding steroids? No, it's because of the side effects. And, I love diary, so does my daughter, but I don't think the answer is do a diary. And so the answer is, of course, observe the inhaler technique. And especially, these inhalers nowadays, folks, they're so confusing. There's so many different types. There's all these lip to this and lip to that. So it's good to actually let your patients see how they're using their inhalers. Great job, everyone. So this is probably the trickiest slide here, so I apologize preemptively. So when I put this here is because all those biologics are confusing everyone. And why did I put this here? So even on MixApp 18, they have so many biologic questions on there. So it's definitely fair game for the board exams. So what am I putting here? What does it mean, Th2 pathway? Well, TH stands for T helper cell. So that's the most immunology I'll go through today, is that when you think about, immunology, that remember you have your lymphoid pathway. The lymphoid pathway has T cells and B cells, right? And B cells turn into what? Plasma cells, and they make antibodies. And what antibody do we really care about in asthma? IgE. Then when we have the T cells are always the regulators of the immune system. There are two types of T cells, CD8, which are called cytotoxic. We're not going to do anything with those, and CD4, which is the helper. And the helper T cells have so many subtypes, but the one that's most important for asthma is the T helper subtype 2. And that's why when we talk about these immunological drugs, they're really going to target what? IgE and the Th2 pathways. And the Th2 pathway has 3 main interleukins that are involved with it. It's IL-5, IL-4, and IL-13. So what did I draw here? I just kind of combined pharm and phys together. So IgE, which is going to be made by that plasma cell, and you're going to have it because of your adaptive immune system. You're going to make a lot of IgE to certain antigens. This is going to bind to mast cells and Th2 cells. And they're going to release the 3 main interleukins, IL-4, 5, and 13. IL-5, all of them are all going to directly affect what? Eosinophils, which is why it's the main cell that causes inflammation in asthmatics. And when we talk about the drugs that are going to be affecting this, well, we all know and love the Xolair, which is going to block IgE to prevent it from binding to Th2 cells and mast cells. IL-5 is a huge one. That directly affects eosinophils. The IL-4-13 combo, there's a drug that combines them together. It's called dupolipimab. Not only do they affect eosinophils, but they also directly affect the airway itself by helping out with airway epithelium and smooth muscle. So this is a nice one to do a once-over on, and we'll talk about each of these new, air quote, new drugs in terms of biologics. The default is these are very expensive. The default is that they're never first line. The default is that all these are for extrinsic allergic asthma. And usually after you exhaust normal inhaler therapy and you're still symptomatic, then and only then would you commit patients to these biologics, because they're biologics and they have side effects and they're expensive and you have to inject most of the time. So of course they're going to be after traditional therapy first. So the most classic one out there is always going to be omalizumab, which is Xolair. And this is one based upon IgE level. So how do you know which one to use? The easiest one is always going to be omalizumab Xolair, because they should have an elevated IgE level. They need to have an elevated IgE level. This is a shot that you have to give in a healthcare setting, and we give it in people with, severe persistent allergic asthma refractory to therapy with an elevated IgE. What happens? It binds IgE so it doesn't degranulate mast cells and rev up the Th2 pathway. It's associated with some anaphylaxis. That stinks. So after you dose it, I know at USC, they have to hang out with my staff for 2 hours after the injection. That's not fun. And we dose it based upon body weight, and we dose it based upon IgE level, and we give it almost every 3 to 4 weeks. So it's a commitment if you want to use it. And patients who are on it do have to carry an EpiPen. So should you follow these IgE levels that you need to order after starting Xolair? What do you guys think? Oh, wow, the 20% kind of threw me off. That was supposed to be a joke. At least you're an honest class, you know. The answer is no, because does anyone just want to take a guess what happens to IgE levels after you start Xolair? What happens to them? Do they go up or down? They go up, because if you prevent it from binding to a mast cell or a Th2 cell, total serum IgE will go what? Up. So the instinct in most people are like, oh, IgE is going up. You may increase the dose or the frequency. So it's based upon symptoms. We don't follow IgE levels. So here's the IL-5s. There's 3 of them out there, got FDA approval. And I just put the brand names because they're just easier to say: Nucala, Faserna, and Sincair. And you can just take an X and cross out Sincair. That company is going to go bankrupt pretty soon. So it really comes down to Nucala and Faserna. And those are going to be mepolizumab is going to be Nucala. So when we talk, and benralizumab is going to be Faserna. And so these are all going to be working on the IL-5. Remember on my little slide a few slides back, interleukin-5 directly affects the eosinophil, and eosinophils cause all the damage in the airway in an asthmatic. So when do I think about using an IL-5? They all got approval for patients with asthma that's severe, persistent, refractory to regular therapy, and they don't have an elevated IgE, but they have peripheral eosinophilia. And they have a specific cutoff that they mention to use these drugs. It's not really a very high cutoff, but they want you to have peripheral eosinophilia to get the approval for these medications. So the ones out there, this is Nucala. It came out first of the big 3. And I put this little picture to keep it simple. IL-5 affects eosinophils. That causes inflammation. This drug, you have to go to a healthcare setting. They have to inject it. The only good thing about it is that it's fixed dose, so you don't have to, it's not dependent upon weight like Xolair is. But the bad side is, like Xolair, you got to reconstitute it. You got to make it before you inject it. That's kind of a pain. And notice on the bottom over here, I put something about herpes zoster. So when it got FDA approval, they noticed in their trials that people had reactivation of herpes zoster. That stinks. So we have to, most of the time, if you read the label, they want you to get the herpes vaccine, which nowadays is not really a big deal because it's not about Zostavax anymore, is it? It's about Shingrix, you know? So you could give it to these patients because they don't have to be older in age to get it. So this is Faserna. I really thought this is the one to invest all my money in, but I'm glad I didn't. But this one is going to be, if you look at what makes its claim to fame, less dosing per year compared to everyone else. And the good thing about it, you don't have to reconstitute it. It's not weight-based. You come in less to get the dose, but you still have to come in and it's still going to be a shot. And I would say it was doing pretty well. Same profile. It's people with an IL-5 blocker, people with peripheral eosinophilia, and you could choose between Nucala and Faserna. There wasn't one that was better or not better, but its claim to fame was less dosing and it's easier to administer, so why not? Sincair is IV infusion. So you have to go to an infusion center, put an IV in you to get it. So obviously by practicality sense, no one is on this medication. Unless you're really bullied into being on an IL-5 inhibitor and you didn't actually get any response to the other previous IL-5s. And I put this very elaborate diagram here to once again show what you know already. Who are some of the main players? Mast cells, IgEs, IL-5s, and these eosinophils. And that's doing the same thing. All these IL-5 inhibitors do it. Because it's IV infusion, it just hasn't taken off. And I haven't had any allergist or myself use this medication. This is the one I would take a red pen and circle 20 times. This is going to be probably the big thing coming up on boards, and now it's called Dupixent. This is actually an IL-4/13 inhibitor. And why is it really going to take over is because of my second bullet point, it's self-injectable. Everything else has to be done in a healthcare setting. This is the patient gives themselves the shot. So the dosing, I believe, don't quote me on this, I think it's like it comes in 300 milligrams and you give it initially as a load, 600. Then once every 2 weeks, they self-inject, I think 300 milligrams. And it's just great because of practicality sense. And notice back to my diagram 4 or 5 slides ago that the IL-4/13 inhibitors not only affect the eosinophil, but directly affect the airway too. So this is FDA approved for asthma. many commercials on TV about this, so your patients will be asking you about it. And I have used it already on my patients, and so far, so good. And this is that barbaric procedure called bronchothermoplasty. It got FDA approval in 2010. And basically what it is for, its niche is really the intrinsic non-allergic asthma, even though it's approved for both allergic and non-allergic. But basically this is a procedure you can imagine failed all medical therapy. You have nothing else to offer. Then you offer this, and basically it's 3 procedures that I do with a bronchoscope. Sometimes I have to intubate these patients, and I take my scope, and it's attached with this device here, which is going to be the device that heats up the airway. And why do I heat up the airway? Is to prevent smooth muscle remodeling. You have to do 3 separate procedures 1 month apart. I have to dose you with steroids first. So it's very barbaric, and some people still do it because, for their patients are bullied into it because there's nothing else to offer them. So this is last of the line. It's very invasive. So drugs to be careful for in asthma. I think we all should put somewhere Samter's triad, so aspirin and non-steroidals, nasal polyps, think about that. Of course, non-selective beta blockers are huge. And I put ACE inhibitors there because of bradykinin and the cough, and sometimes the cough can mimic asthma. And asthma-related diseases, I put 2 up there, ABPA and EGPA. So ABPA, think of someone who comes in refractory asthma, and it's not easy to diagnose. It's always about meeting criteria, major and minor criteria. So what are some of the major criteria? Of course, history of asthma. It's also associated with cystic fibrosis. It will have an elevated IgE level. It will have an elevated IgE2 aspergillus antigen. We don't do skin testing as much. You'll have peripheral eosinophilia. And if you do a CT, you have bronchiectasis that's going to be more central in nature. So that's ABPA. How do you treat it? Steroids. Do we use antifungals? Yes. More than not really, this is not an invasive fungal infection. It's more like a hypersensitivity reaction. So we use antifungals like itraconazole, like voriconazole to decrease the antigen load. Contrary to that, on the other side is what we call Churg-Strauss, EGPA. As you know, it's a small vessel vasculitis. This is going to be about 90% of these patients who have Churg-Strauss are associated with asthma. And a couple things, they also will have an elevated IgE level. It will also have peripheral eosinophilia. And of course, you got to look for signs of avasculitis. And that's why you would think of things like arthritis, neuropathy, skin lesions, all those rheumatological things. And of course, antibody-wise, if I suspect Churg-Strauss, I always think about a Pianka with my favorite anti-MPO right after that. But these are going to be anti-mimickers of asthma. And kind of cool, if you want to write this down, those IL-5 inhibitors, there's one in particular. It's called mepolizumab Nucala, the first one that came out. I don't know if you guys knew this or not. It actually got FDA approval for Churg-Strauss. It's the first biologic that got FDA approval for Churg-Strauss. So kind of interesting little fact right there. So COPD. So by definition of the GOLD, Global Initiative for Chronic Obstructive Lung Disease, I put down 3 bullet points. Number 1 is preventable. And remember, COPD is not only about please don't smoke. I mean, it could be environmental, it could be fumes, or it could be alpha-1. But of course, we think about the smoking component. The second bullet point I wrote down is reversible. That's not like a typo. So that really changed in the definition because now asthma is part of the COPD family. So an asthma is reversible. So they changed the definition to being reversible because asthma is part of it. But the last part, it's noxious particles, and that hasn't changed. Cigarette smoking is bad, fumes are bad, environmental exposure is bad. They directly damage the airway itself. So when we think about COPD, of course, traditionally it's emphysema and chronic bronchitis. And then notice the third bullet point is something called ACOS, asthma COPD overlap syndrome. So we think of it like this over here nowadays. And that's the big thing when we talk about, using inhaled corticosteroids in COPD. Is there an asthma component or not? And that will really drive me to say using inhaled corticosteroids in these patients. So these are going to be some of the phenotypes that we think about. So when we think about severity, severity is based upon the classic GOLD criteria is based upon airflow, and we don't use that anymore by itself. We do what's called a combined assessment. So in the olden days, if we just did the gold classification based on spirometry, all of these are defined as a ratio less than 70. Mild is going to be the FEV1 greater than 80, moderate 50 to 80%, severe less 30 to 50%, anything less than 30 is very severe. And I did give some of the tips of what we add. So for mild COPD, we always start off with lifestyle modifications and short-acting bronchodilators. And actually, that was one of the questions on MixUp18. Only when do we hit the moderate amount that we add LABAs and LAMAs together. So I really do think this is a nice slide to do a once-over, considering what do we add just only based upon spirometry. But if you ask me how do we rate severity nowadays, it's what we call the combined assessment. And it's a combined with spirometry from the previous page and these patient risk factors. And what are those risks to mean that you're going to have a poor assessment? Have you ever been admitted to the hospital? Have I ever had to be blasting you with systemic steroids? Those are huge things. How many exacerbations have you had in the last year? So we take those pieces of information, combine it with the spirometry values to give you what's called a combined assessment. So what do we do if I wanted to calculate it out? They'll never ask this on the board question, but what I do is I look at a couple things. Number one, there's questionnaires to see how bad you are. There's 2 questionnaires that they use. The classic one is the one over here on the right called the MMRC, because it's just short and you can ask these questionnaire. And the higher the number, the worse the patient's going to be. And then the second thing we do is the risk of exacerbations based upon, well, did you get hospitalized before? How many exacerbations have you had in the last year? So based upon that, I'll put it in one of these boxes over here. And now when I'm doing my pulmonary clinic with my fellows and someone with COPD comes, they usually will say something like, patient is a 1A, 1B. The 1, 2, 3 comes from the spirometry in itself. And the ABC will come from their history. If they were on steroids, did they get admitted to the hospital? What was their questionnaire score? So now we have a way of classifying things. And the reason why we do this is because I'm sure many of you guys had a patient who had an FEV1 that's super low, but they do great clinically, and vice versa. And that's why combined assessment is very important on these patients. So how do we treat COPD? Well, I usually say this for any disease in general, but I always say that you always want to do things that reduce mortality. So it doesn't matter what disease we're talking about. Things that reduce mortality always trump. And when we think about, what reduces mortality in chronic COPD, well, there's a bunch of things, right? It's not just one thing anymore. So what are the things that reduce mortality in chronic COPD? I would say stop smoking, right? So that would be right here in bullet point number 1. And how do we do that? Well, doing different modalities together are the best. So lifestyle modifications plus cognitive behavioral therapy plus nicotine replacement is better than doing one by itself. Drugs-wise, there are 2 FDA-approved drugs. One is brand name Chantix. It's a 12-week starter pack, usually at the 1 to 2 milligram dosing. Of course, be careful with depressed patients, but I give it quite commonly. It works great. Bupropion, you guys called that Wellbutrin XL, really works well also. Be careful of seizures in patients. That's a classic buzz board pearl right there. But of course, you want to do combined things already. And we'll talk about other things also like oxygen and mortality reduction, but many things can do it. But there are things that patients with COPD will be on just to feel better, things like bronchodilators. We'll talk about the role of inhaled corticosteroids, which is very, very controversial. We'll talk about oxygen, and we'll mention about things that can reduce exacerbations, because the more exacerbations you are, the worse overall prognosis it's going to be. And we'll mention really briefly some things about surgery and pulmonary rehab. So for bronchodilator therapy, if you're going to be all patients with GOLD stage 1 needs to be on short-acting. The minute you hit stage 2, you should be on the longer-acting LABAs and LAMAs. I would say you would pick a LAMA before a LABA. Why? Is mainly because of one trial called the Uplift trial, if you want to circle that with the red pen, because of the fact that tiotropium has been shown to reduce exacerbations, so it's the preferred long-acting that we use up front. But it's not wrong to use a LABA if you want to. And then, of course, the long-actings also got FDA approval for that. And then, of course, methylxanthines mean maybe we use them clinically, but not for board exams. Many side effects on that. So if we use methylxanthines orally, it's usually because we're bullied into it, and it's an oral drug. You take it once a day, but very few people are on it nowadays. So I put this slide here just to have the criteria of when do we start home oxygen. I wouldn't bother memorizing this. I just wanted you to have it in your slide deck. And when we talk about oxygen, yes, it does reduce mortality. Yes, you have to use it quite a bit, almost 24 hours a day. And I do feel bad. Anytime, I think many of us, including myself, don't realize what a life changer it is to give a patient home oxygen. You're on a concentrator at home with a 50-foot tube that you're attached to. It's hard to go anyplace. If you want to be mobile, it all depends on your liter flow. If you're more than 3 to 4 liters, you really can't do anything outside the house. So it's really sad when patients have to be on home oxygen. Lung volume reduction surgery, I would circle this. It's surgery, so it's not going to be first line. It's surgery, so it's people with severe COPD, maximized on medications. And the key thing about offering this surgery is that, what is it doing? It's taking out bad lung. Literally, it's chopping it out. So if you have one lung that has a lot of blebs and bullae and all this stuff, you just want to literally take out that lung. And by doing that, it improves VQ matching. And who would benefit from this procedure? The studies have shown a very, very specific target patient, which is someone who has disease of the upper parts of the lung, the apices of the lung. And not only do they have that disease in the apices, it has to be heterogeneous, where one lung is going to be worse than the other when we think about it. So in these patients, if you actually they maximize on medical therapy, they fit that profile. If you take out one of these lobes that's damaged, it actually will show some survival in this specific group. And the way I'm showing you here is the invasive way to do it, which is actually going to be a surgical procedure, lung volume reduction. Lung transplant, ironically, it does actually improve survival. So I would actually write that down or circle it right here. It does improve survival. And when we talk about that, yes, they will still have to face immunosuppression, infections, and all this stuff. And people can get a single or double lung transplant and still get the survival if they have COPD. So a 59-year-old man has a long-standing history of COPD with chronic bronchitis. Is evaluated and followed up for his most recent exacerbation 6 weeks ago, which necessitated a visit to the ER. At that time, he was treated with 7-day outpatient course of oral prednisone and azithromycin. His symptoms are now at baseline, but still has a productive morning cough, which is minimal. Patient reports that he had dyspnea climbing stairs, but he is able to work as an accountant without difficulty. He smoked 2 packs of cigarettes daily for 20 years, but quit at age 50. He has had 2 exacerbations in the past year. His current regimen is tiotropium, Advair, and he's on the 250/50. On exam, he is a febrile normotensive, non-tachy, non-tachypnic, spirometry. His FEV1 is 45, his FVC is 58, his ratio is 61, and he's saturating 93 on room air. And for what it's worth, they checked an alpha-1 level, which was normal. Which of the following should you recommend to reduce the frequency of this patient's exacerbations? Take a quick look at that, and I'm going to press the countdown. Yeah, you guys are awesome. So, anytime it says pump the patient full of steroids, that's always the wrong answer. C, changed to the higher dose. So this is more of a stickler question. Advair at the 550 dosing is usually for asthma. It didn't seem like there was a big asthma component here. I think this patient's phenotype was chronic bronchitis. I put that in bold, D, well, you just can't discontinue it. You know what I mean? You definitely need him to be on the LABA, But I like the ending of D, which is adroflumilast. And of course, B was the right answer. So the big thing about this question is reducing exacerbations. There's really only 2 drugs that we think about to reduce exacerbations. One is this one, roflumilast. It's called Dalaresp. And its claim to fame is mainly in patients who have the chronic bronchitis phenotype, and that's what this patient had. Sometimes it's expensive. I think it's going generic soon, hopefully. And the other drug that reduces exacerbations in COPD is an antibiotic. And what antibiotic is that? Azithromycin. And it's going to be 250 a day, every day, for a very, very long time. And like I said, anytime you give a macrolide, always get that EKG, because it's one of the many things that prolongate QT interval. 68-year-old guy with history of COPD, FEV1 in the PaCO2 measured under stable conditions is 550 mLs and 58 for the CO2. So it sounds like he's a chronic CO2 retainer. Patient was admitted with a 3-day history of increasing cough, sputum, and dyspnea. His only meds are inhaled beta-2 agonist, inhaled anticholinergic. He weighs 65 kgs, which is not good, weight's low. He is febrile, heart rate, respiratory rate's 28. He has irregular heart rate of 120. And if you have the irregular heart rate and it says huge history of COPD, what arrhythmia sometimes jumps in my mind? Yeah, multifocal atrial tachycardia. I'm not saying it has to be, I'm just maybe. Blood pressure is 100/65. He's using accessory muscles of respiration and appears anxious. Heart sounds are diminished and breath sounds are decreased bilaterally. Chest x-ray, over there on the right, hyperinflation, no pneumonia, pneumothorax, or heart failure. They do an ABG, now that he's on 5 liters, and that CO2, it went up. It's now 74 from the baseline. They do a rhythm strip and look at the 3 different morphologies of those P waves, and it's irregular, it's MAT. In the management of this patient we just pictured, describe which of the following, reduces mortality, love these mortality questions, in severe acute exacerbations of COPD. All right, here we go, guys and gals. All right. So when I look at this, number one, does oxygen reduce mortality acutely in any disease? The answer is what? No. Hey, I'm down to stop smoking. I'm willing to lie to my patients to stop smoking. But does stop smoking going to reduce mortality acutely? No. And steroids, does that reduce mortality? No. So the answer is other. So we just do a yell out the right answer. Who could tell me what's the only thing in COPD management acutely that reduces mortality? Just anyone yell out the right answer? BiPAP. You guys are awesome, man. Yay. So when we talk about BiPAP, you know what the big thing is that beyond evidence-based medicine, you don't want to intubate patients with COPD, right? That's not good because it's hard to get off the vent. So at least bi-level gives you a chance as a little buffer to prevent intubation, do what you want, give the steroids to work. And I usually think about bi-level in 2 diseases. I definitely think about it in CHF, and I think about it in the terms of reducing the preload and work of breathing. But definitely in COPD, just don't try not to intubate them. So this is great, and there's really great data that shows that it reduces mortality acutely. 62-year-old woman is evaluated in ED for a 2-day history of increasing dyspnea. She has advanced COPD with an FEV1 of 35% of predicted. She has a 75-pack year history of smoking and continues to smoke. Good job. Her continued medications are tiotropium and albuterol. She's difficult to arouse, a febrile, normotensive, non-tachy, tachypnic. BMI is 30. Lung exam discloses prolonged expiration and wheezing. Bilateral pitting edema is noted. And the O2 stat is 93. All right. Which of the following is the most appropriate diagnostic test to perform next? Here we go. Cool. So this is more of a traditional type question right here, right? It's like, what is the next best step in management, So anyways, why did everyone pick arterial blood gas? What was the buzzword in the vignette that really tried to push you to pick this? Yeah, it's difficult to arouse, right? And when you're difficult to arouse, you want the ABG to show what? See if they're hypercapnic. Is that going to change your management? Yeah, it really depends on how difficult to arouse are you, right? Of course, if they're kind of difficult, maybe like a BiPAP to wake up, they're super obtunded. You got to intubate them, obviously. But yeah, this will definitely change your management. Why did some people pick echo? What distractor did I put in there to pick echo? The lower extremity edema, right? Everyone always kind of gravitates towards the heart. But can you have lower extremity edema with really bad lung disease? The answer is yeah. What is that called? Cor pulmonale. '63-year-old woman who had I think this is the hardest one. So I put here. So pre-apologizing if you don't dig it. 63-year-old woman who had a COPD for 10 years is evaluated because of easy bruising that's making her increasingly self-conscious. 3 years ago, the patient had one hospitalization related to an exacerbation. 1 year ago, she had an exacerbation that was treated with oral medications at home. She has had no exacerbations since. The patient quit smoking 3 years ago, and she does not have cough and sputum. She is physically active and able to do her own shopping and housework. Her current medications are Advair twice a day, Spiriva once a day. This regimen has been unchanged since her hospitalization 3 years ago. On physical exam, a febrile, normotensive, non-tachy, non-tachypnic. FEV1 is 45% predicted. And this has been unchanged for the last 3 years. And her O2 stats 92 on room air. Which of the following is the most appropriate recommendation for this patient? So just take a quick look at the answer choices, and then I'll press the counter. All right, here we go. Okay, I mean, at least I apologized first, so, you know. So why did I put this question here? Is because of the spiciness of those inhaled corticosteroids. Remember I told you that's a really controversial topic? Because of the fact that there is data to show that if you give inhaled steroids, it may give you a higher risk of pneumonia. And what is really inhaled steroids doing for emphysema and chronic bronchitis? Pretty much nothing, right? Because when we talk about classic COPD, that's a disease of noxious particles, not a disease of sensitizing particles. When you talk about the immune system and sensitizing particles, sure, that's where we use inhaled steroids for those asthma-like patients, right? So it's always a risk and benefit. But nowadays, for classic COPD without an asthma component, you know, a lot of data is out there to say we just want to put them on bronchodilators. And that's why these LABA-LAMA combos came out there and people are making a lot of money off of them, you know? So when I look at this answer choices, well, does this patient have a complaint? Yeah, she was having what? The bruising, right? And what is probably causing that bruising? Steroids, right? Maybe I see that more when I'm giving systemic, you know what I mean? But you can get it sometimes. So is this patient's COPD stable, yes or no? Yeah, I put buzzwords like 3 years and all that stuff. So, you know, you can't just pick A, do nothing. You know, she has a complaint. You know, you just can't say B, hey, adios to the LABA, even though you don't need the inhaled corticosteroid, you still need the LABA, so you just can't do B. And then choice C means that, well, I don't like Advair, but Symbicort has great drug dinners, so I'll do Symbicort instead. You know, you can't do that. So the only one that really makes sense is that let's taper off the Advair because we don't need the fluticasone. That's causing all the problems. But I'm actually just going to give a single LABA, and the LABA is what? Indacterol. So it's going to be indacterol combined with, what was she on? Tiotropium. That's the LABA-LAMA combo. So the answer is going to be D. And this is one of the many articles out there that were showing about how in certain individuals, LABA-LAMA are the way to go because you may not need the inhaled corticosteroid. So let's switch gears a little bit and talk about ILD. So when we talk about ILD, I want you guys to embrace it and love it. They're really, really fun. I think people get intimidated because there's so many different diagnoses. And ILD is kind of a misnomer. It only kind of implies it only affects the interstitium, even though many diseases will have alveolar and capillary involvement also. And when you want to diagnose ILDs, everyone, well, what I'm going to do is kind of tell you what all interstitial lung diseases share. I'm going to talk how to diagnose any of them, and then we'll talk about specific types, okay? So I think of ILDs kind of like nephritic nephrotic syndromes. Why? It's because, if you really want to know if they're nephritic and what the exact etiology is, what do you got to do? Biopsy. It's not like a secret, Same thing with ILDs. If you really, 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 really want to know, you do need tissue. I'm not saying do it in all patients, but you really need tissue. And in general, how do we get tissue in our patients? Do we do the most invasive thing first or the minimally invasive? Minimally invasive. And when it comes to pulmonary, what's probably a minimally invasive thing to do that could kind of get you tissue? Bronchoscopy. I'm not saying it's always going to give you the answer, but that's probably what we want to evaluate first. So when we talk about ILDs in general, if you really want to know what it is, you probably need tissue, and we'll probably do something minimally invasive first with a bronchoscope. Nowadays, there's so many toys with the bronchoscope. You could do the classic bronchoalveolar lavage, which is getting the fluid back. You could do a transbronchial biopsy. But nowadays, many of my fellows practice something called EBUS, which is an ultrasound where you can needle the lymph nodes nicely. And there's other things too. But when we say the word bronch, you know what I mean? Obviously, there's an interventionalist that's going to tell you exactly what they're going to do with the bronch. And all these are, air quote, minimally invasive. If you get the diagnosis, great. But if you still don't make the diagnosis, there's not a pathologist in the world that would not like to say, I need more tissue. You know what I mean? So, of course, if you need more tissue, you need to do a surgical biopsy, and those are ways we can do it. So what do all ILDs share in common? Well, they're all going to have some dyspnea on exertion, the most common symptom. Most of the time, they're going to have bilateral chest x-ray findings. They're going to be chronic in nature, whether it's going to be a chest x-ray or a CT. Most of them will have a classic PFT pattern, the classic one being restrictive intrinsic, which we talked about, and most of them will have a widening of something referred to as the AA gradient. No matter what ILD we talked about, they most likely will share these things, and will most likely diagnose them based upon bronchoscopy first, plus or minus something invasive if we don't make the diagnosis. So how do I categorize ILDs in general? I made this for you guys. You can put a little star at the top of the page. And I'm just saying that all ILDs, to kind of categorize my thought, I put them into two types. One will be occupational, the other will be non-occupational. When we talk about occupational, I subcategorize those of ILDs secondary to an inorganic cause or an organic cause. So the inorganic are the classic things that you think about, like asbestosis, silicosis, borreliosis, and in general, folks, are we seeing these diseases more and more or less and less? Less and less. So they're 0 on the IM board exams, When we talk about the organic type, the classic example is hypersensitivity pneumonitis, where you have like a organic trigger, some kind of mold of some kind, But still, I would say it's more of a pulmonary board question, not so much a IM question. But here's where they really thrive, is the non-occupational. And there is a plethora of those. I didn't put, connective tissue diseases, ILDs, drugs, ILDs. There's so many that could be in this place. But the two that they've asked over and over and over again on the IM board exams is sarcoidosis, which we're going to spend some time with today, and something called IPF, idiopathic pulmonary fibrosis, which is a horrible, horrible disease. I wish it upon no one. And then underneath it, I wrote down UIP. Why? Is because IPF is the clinical diagnosis. But if you biopsy, I'm not saying you need to, but if you biopsy him, what would the pathologist read out? They would read out it has what we call UIP pattern. So many times we will use the terminology UIP/IPF, or UIP implies IPF. So just to kind of throw it out there so you won't be confused with the terminology. But anything that I put here, how do we work them up? Same thing on this slide, how we diagnose it. They all present with these things over here regardless. And now I'll just give you a couple pearls, about the two most common things, sarcoid and IPF. So if you were to ask me, like, clinically, what disease am I super, super passionate about? It's definitely going to be sarcoid. I mean, I think that I run a sarcoid clinic at USC. I just really enjoy sarcoid because it's a disease of every single organ in the body. It doesn't need me to be a pulmonologist. It needs me to be a great internist. So I love sarcoid. And I love sarcoid because many people just don't care or know too much about sarcoid. And everyone's like, no, I care. And I'm like, okay, let me ask you a question then. Class, What is the color of sarcoidosis awareness? There you go. So, and I feel sarcoid got a bad rap, because if I say, what's the color of breast cancer awareness, what would it be? Pink. What's the color of heart awareness? What about sarcoid? Okay. Yeah, it is purple. And so, in what month is Sarcoidosis Awareness Month? April. So anyways, when we talk about a sarcoid, it's a disease of every single organ in the body. And what I'm going to do is kind of like start off right here in the slide where we talk about the skin and the eyes and everything. So of course, when we think about sarcoid, it's always a diagnosis of exclusion. You always have to rule out other things first. Cancer, cancer, cancer. You always got to rule out infections like fungus and these mycobacterium. But can sarcoid affect the eye, everyone? The answer is yes. And what can they do in the eye? It could cause uveitis, both anterior and posterior. So you definitely need the ophthalmologist to look in the eye. Because when we think about the uvea, remember that always is going to be when we talk about the ciliary bodies, when we talk about the iris. But the most important part is what? The choroid, which is the back part of the eye. It's the layer between the sclera and the retina. So you got to know if there's posterior uveitis. It can cause retinal vasculitis, scleritis, episcleritis. So definitely sarcoid in the eye. And when we talk about sarcoid class, there's 3 organs that scare me when they're involved. And the 3 organs that always require therapy and treatment are what? The eye, the CNS, and the heart. The minute you have those involved, there's no ifs, ands, or buts. I'm going to treat you. Lung, whatever, you got lung. I mean, all right, I might treat you, I might not. And my job as a sarcoid specialist is to actually decide who needs treatment, because anyone can blast anyone with steroids, right? And that may not be the best thing for that patient. What else can sarcoid do? It could definitely affect the skin. And the skin is actually the second most common organ involved when we talk about sarcoid patients. Lung is number 1. And the way I think about sarcoid skin is I put them into 2 broad categories. Number 1, you could see skin lesions that are secondary to granulomas. So when you biopsy, you see a granuloma, like plaque sarcoid, papular sarcoid, sometimes around the hairline and stuff. So I could just see stuff, and sarcoid mimics many, many, many different things on the skin. The other type of skin lesion is ones that have nothing to do with granulomas at all, but they're associated with sarcoid. And the 2 ones I've seen on board exams is number 1, the classic one we love, which is erythema nodosum. And you know that erythema nodosum can be second to a plethora of things. Inflammatory bowel disease, many fungal infections can cause that, many bacterial infections can cause it. And if you think about what is probably one of the most common bacterial infections that cause erythema nodosum, that would probably be what? Yeah, group A strep pyogenes, very good. So when we think about, other things associated with sarcoid skin-wise that are not granulomatous, sometimes there's this disfiguring skin lesion on the face that we see sometimes. It gets a really catchy name. Does anyone know what that is? Lupus pernio, very good. And that's kind of like a discoid lupus. Has nothing to do with granulomas, but they're associated with sarcoid. So sarcoid definitely loves the skin. When we talk about the heart, the most common thing in the heart is always going to be conduction abnormalities. So you think about heart blocks, but sarcoid can definitely involve the heart itself, like a restrictive cardiomyopathy, just to name one. And of course, GI tract, CNS, bone marrow, spleen, you name it, I'm going to say yes, yes, and more yes. But pulmonary is always going to be the most common. When you shoot a chest x-ray like here, you get what's called hilar fullness. This is classic stage 1 sarcoid chest x-ray. And remember, if you really want to diagnose sarcoid, you really can't look at this and say this is lymphadenopathy. You really need a CT with contrast to determine what's vessel and what's going to be lymph nodes. So that's why most of us will get some kind of CT chest to really confirm if it's going to be the lymphadenopathy. I put some syndromes. I'm not a big fan of syndromes. They're just memorizing stuff. But Lofgren's is going to be the combination acutely of erythema nodosum, hyaluronidenopathy, and arthritis. The other one is not as common at all. It's called Herdorf syndrome, but it's probably worse. Why? You have uveitis, that's going to be the eyes. You got facial palsy, so that's going to be the CNS. So you can imagine, and look at the 3rd bullet point under there. It's parotid gland enlargement. So, sarcoid mimics a lot of things. And what rheum disease mimics sarcoid sometimes? Sjogren's. definitely with that parotid gland enlargement. So you have to look at the big picture. So I already mentioned this, diagnosis of exclusion, and the only way to diagnose sarcoid is tissue, tissue, tissue. You have to get tissue, and that's where we do imaging for, right? Because I don't always diagnose sarcoid in the lung. It's the most common, but sometimes I could diagnose it based upon having a lymph node. Sometimes it's scary because if it's CNS sarcoid, that's when I order PET scans and all these different images to find where else can I easily get the biopsy. And it's hard to biopsy the heart, the CNS, the eye, all these things. And that's why we do this imaging workup. So this over here, folks, is an EBUS. This is going to be the ultrasound at the tip of a bronchoscope where I take a needle and I could needle some of these mediastinal lymph nodes if I want to get tissue. So when we talk about sarcoid, it really matters what organ is involved, and if we want to treat symptomatic sarcoid, there are only 2 drugs that got FDA approval for symptomatic sarcoid. That's going to be prednisone, and a drug called Acthar, A-C-T-H-A-R, which we'll talk about briefly. But when we talk about sarcoid, well, no one wants to be on long-term steroids. I always kind of put on my rheumatology hat when I talk about this because even at 5 milligrams of prednisone, a rheumatologist hates it. Same with me, because the side effects of prednisone outweigh the benefits of starting a steroid-sparing agent. And I always tell my patients that, you come in with sarcoidosis, and when you leave, you'll get another diagnosis. It's called steroidosis. And that's what happens, because there's so many side effects. So what I want to do in these next couple slides is just kind of talk about these drugs that we use as steroid-sparing agents, because I feel it's going to benefit you not only in the pulmonary section, but when you do rheum and in general, because for an internist, they really care about the side effects of the drugs. That's what you should know for the board exams. So methotrexate is probably my staple drug as a steroid-sparing agent. Remember, methotrexate, they still love these on IM board exams, is how does it work? It's a purine synthesis inhibitor. It inhibits the enzyme dihydrofolate reductase. That's why we always give what? Folic acid. Sometimes they are on leucovorin as an alternative. And the most common side effects are always what? GI. So that's why when we give methotrexate, you start off at 7.5 milligrams and you slowly titrate up because of the GI side effects. Sometimes you give it IM if you don't like the patient. And then, no, I'm just joking. But it bypasses the liver, so you don't get the GI side effects. And sometimes it'd be a little more potent if you do it that way. You always have to check hepatitis B and C before you initiate the drug because it is toxic to the liver. It suppresses the bone marrow, so you have to do a follow-up CBC. And remember, many of these steroid-sparing agents for rheum or sarcoid, they don't work right away. You have to be on these medications at least 2-3 months before they start working. But methotrexate would probably be one of my go-tos as a steroid-sparing agent for someone with sarcoid. Imuran, I'm using the brand name here, very common medication. I think many people forget it's weight-based, you know what I mean? It's not just what we memorize, 50, 100, 150, 200. It's weight-based medication. Common side effect is always going to be GI, so we slowly titrate up. We always want to follow up a CBC when we're on it. And on the third bullet point, you could circle the enzyme TPMT. What enzyme breaks down the metabolites of Imuran? It's thioprine S-methyltransferase. And sometimes rheumatologists will check that prior to starting the drug. You don't have to, and you still can give it even if you're low in it. But people who get the side effects probably are going to be low in this enzyme. Leflutamide tends to make it a lot on boards. Why? It's the brother of methotrexate, so it works on the pyrimidine synthesis inhibitor. In rheum, it classically gets combined with methotrexate, but when would I use it is if you have the pulmonary side effects of methotrexate. So for sarcoid patients, I don't usually see the pulmonary side effects because I dose it less than a rheumatologist. I'm more of a 15 to 20 type of guy when it comes milligrams per week when it comes to methotrexate, much, much lower than when I see the lung toxicity for methotrexate for cancers or for rheumatoid arthritis patients. Leflutamide, its claim to fame is people who can't tolerate methotrexate because of the pulmonary side effects. Antimalarials, everyone seems to love antimalarials. They're very, very weak anti-inflammatory. Hydroxychloroquine, don't get me wrong, every patient on lupus should be on what? Hydroxychloroquine. There's no questions asked. But in the sarcoid world, there's really a limited role for it. What you should know for board exams is you always want to see an ophthalmologist first because of the retinopathy, which is non-reversible. And of course, they love to ask the internist, what level do we check before initiating hydroxychloroquine? G6PD levels, right? We don't want them to become anemic. The next thing you know, you're like, oh, there are some bite cells. Oh, hello, Heinz body, So you don't want to do, you want to check a G6PD level first. Very, very weak anti-inflammatory in sarcoid patients. TNF inhibitors, I think that you got a very good talk during your rheumatology, hopefully. And TNF inhibitors, only two I use in sarcoid, only two. Remicade, which is infliximab, and adalimumab, which is Humira. Those are the only ones that I would use in sarcoid patients. And of course, as rules of thumb, you always want to rule out TB first, and we'll talk about TB during our time together. And what two viruses must always be evaluated before starting a TNF inhibitor? Hep B and Hep C. So you always want to check those first. Good. And when I think about TNF inhibitors, very few pulmonologists are comfortable giving any of these drugs. You want to be familiar with the dosing, and you want to be familiar with side effects. But I would probably use these TNF inhibitors for things like CNS sarcoid, uveitis. That's what they got the approval for. But it's not a very common drug that I use in sarcoid patients. And CellCep, I use the brand name, works on lymphocytes. And remember, back to our immune system, when you want to make granulomas definitely need lymphocytes to form a granuloma. So that's what CellCep is. It works on lymphocytes. If we're talking about scleroderma lung, remember, CellCep has great data for scleroderma lung, the fibrosis you get. But for sarcoid patients, it just doesn't, work as well. I don't commonly use CellCep. Major side effect, once again, is GI. And last but not least, before we move on to IPF, I mentioned Acthar really quickly. Acthar actually got FDA approval. All the other drugs I mentioned are not FDA approved. They're used off-label, but they have a lot of data behind them. And what is Acthar? Acthar is more than just a steroid. It's called Acthar because, do you remember your hypothalamus releases CRH? That goes to the anterior pituitary, releases ACTH. Well, what happens is the company added an AR to that and called it Acthar. So it does two things: a steroid-dependent pathway where you release more steroid from the adrenal gland, but it also works on this non-steroid-dependent pathway through what we call melanocortin receptors. So it's injectable, it's expensive, but for a board review class, I call it steroids light. You get some benefit of the steroid without a lot of the side effects. Most of its immunomodulating effects come from working on these melanocortin receptors. And that's what I showed over here, that all these melanocortin receptors are on things like lymphocytes, are attached to these cytokines, are attached to all the things that form granulomas. "65-year-old female is evaluated for a 10-month history of cough and dyspnea. She reports no other symptoms or medical problems. She takes no meds. She is a former smoker with a 20-pack-year history. She has no pets. On exam, blood pressure is 120/70, heart rate is 80, respiratory rate is 24, oxygen status is 87 on room air. There's no JVD. Cardiac exam is normal. Lung exam, inspiratory crackles at the bases, and clubbing on the fingers is noted. PFTs, the TLC is low, FEV1 is low, FVC is low, the ratio is normal to high, and the DLCO is also low. They do a CT scan, and I think the answer is going to be here, where you notice stuff over here in the periphery, up here. Which the following is the most likely diagnosis? You saw those 4 choices. Just pick one. And you guys are amazing, because when you look at that CT scan, those peripheral findings I was showing you, what's the magical word I'm looking for? Honeycombing. That's what we call honeycombing. So this is probably going to be IPF. So when we talk about IPF, needless to say, it's a diagnosis of exclusion. So what do I think about? I think about a vignette that's going to be super long. It's always going to be like a 65-year-old male or female, and it's going to start off with, has no occupational history, no recent travel, no new drugs, no family, no friends. You're like, what? I mean, they say all these things because it's a diagnosis of what? Exclusion, okay. And you always look for drugs that can cause IPF. And when I think about board exam, what are the big 3 drugs I always think about that cause fibrosis? Number 1, methotrexate. Number 2, bleomycin. And number 3, amiodarone. And on exam, they tend to have clubbing, not the only disease that has it. The workup, look on this side of the column over here, is circle CT chest. Things have changed with IPF. We don't have to go around biopsying them anymore, which is great because it's invasive. Many of the patients have complications from the biopsy. So now we can make the diagnosis based upon very specific radiographic guidelines, and I'll show you that in a second. Of course, PFTs have the classic intrinsic pattern. And of course, if they say gold, most accurate, nothing beats tissue. But it's very important to realize nowadays, we don't have to biopsy everyone with IPF based on the new guidelines. And that's what I put here. You will not have to memorize this for a board exam at all. But the whole point is that the radiologist divides this IPF into a typical, probable, and intermediate. And what happens is, folks, if they say typical pattern right here, you could just do a radiographic diagnosis. Anytime the radiologist says probable or intermediate, oh man, what does that patient need? Biopsy. And how do we do it first? Bronchoscopy. So you got all the answers. So this is what you see on biopsy. And if I were to describe it, I would say on biopsy, UIP-IPF has temporal heterogeneity, meaning that you have normal lung over here, which is our alveoli, versus bad lung, which is, look at this distal cyst, which is a honeycomb. And then what happens is it revs up your immune system and you lay down lots of collagen. And these collagen are what we call fibroblastic foci. So those are the buzzwords that we see when you biopsy. So this is just saying that with any lung disease, including IPF, GERDs is a big thing. Microaspiration can worsen these diseases. So we definitely have a low threshold. There's no side effects to put patients on PPI and correct their underlying GERDs with my lifestyle modifications also. Which of the following is the most common side effect of nintedanib in the treatment of IPF? So this is one of those drugs. Why are they asking these questions to internists? Because IPF, has drugs that will slow progression of disease, and that's great. And sometimes, because it's such a horrible disease, you don't want to wait till they see a pulmonologist, or the wait could be so long. I do have internists that are starting these medications, then doing referral. So this is one of those medications that people are using more and more. It's called Ofev, otherwise known as nintedanib. And what is the most common side effect? Oh, you guys are amazing. Diarrhea. So I put both drugs that got FDA approval to slow the progression of IPF. On the left is the one we talked about, Ofev. The one on the right is pirfenidone. They basically do the same thing. Ofev is a tyrosine kinase inhibitor. Pirfenidone is an antifibrotic. I probably use Ofev more personally because the dosing is much, much easier. It's 1 tab twice a day. The other one is a very, it's a titration that takes some time. One is not better than the other. We don't combine them together. And I listed the side effects that they have. If you were to ask me, are these drugs game changers? No. But, when we think about IPF, there's people probably have a 50% mortality in 3 to 5 years after diagnosis. We have nothing for them. So I'm very happy in general I have something to give them. It sucks that it's so expensive. It stinks that there's so much of these side effects, but at least we have something now for this horrible disease. We always do supportive care, vaccinations, pulmonary rehab. I am very pro giving patients these drugs to help decrease the rate of decline of the FVC. And please look at the last bullet point. It's do not. For chronic therapy, we don't use steroids by itself, and we don't use this combination of Imuran, prednisone, and Mucomyst. There's no data for it. So, of course, always refer to lung transplant, at least get evaluated for it. And please circle the word acute over here. So for acute exacerbations of IPF, so IPF can be quiescent for a long period of time, then suddenly flare up for whatever trigger it is. If they flare up, yes, we use broad-spectrum antibiotics. Yes, we blast them with steroids just in case they might respond. But it all depends on their quality of life and how sick are they. And we immediately start a cytotoxic agent like an Imuran to help taper off the steroids, but it's really not doing much for these patients. These patients are very sad, and the most important thing in these patients is getting them plugged in with palliative care and lung transplant. 77-year-old man is evaluated in the hospital for IPF. He was diagnosed 3 years ago and has gradually worsened despite therapy with prednisone, Imuran, and Mucomyst. All therapy was discontinued over the past 6 months because of failure to respond and side effects. Patient has been homebound on high flow, hospitalized 3 times in the past, just finished another course of levofloxacin, and he has indicated he does not want additional aggressive therapy. On exam, severe respiratory distress, normotensive, tachytachypnic, afebrile, O2 stat, 88% on a non-rebreather, neck retractions, accessory muscle use, bilateral crackles, CBC is normal. I don't know how they did it, but they got a chest x-ray and CT. And here's a chest x-ray, reticular markings on the periphery. CT chest shows the honeycombing. This is this patient, no good. Which of the following is the most appropriate recommendation for this patient? And I'm going to press the go button. Yeah, you guys are amazing. So I think in general, geriatric medicine, palliative care, I'm so passionate about it. It's very important. And the worst thing you can do for this patient is put him on the vent. Oh my, this gives me palpitations thinking about that. Someone always wants to try BiPAP because they're just a good person. But when you think about BiPAP, it's not that pleasant. And you'll never get them what? Off. Pulmonary nodules and lung cancer. So when we think about pulmonary nodules, everyone, I keep it simple. A pulmonary nodule, most pulmonary nodules in the lung are going to be what? Benign or malignant? Benign. Everything is benign. A very small portion is going to be malignant. Of the malignant type, it could be one of two things, right? It could be a primary malignancy or it could be what? Metastatic. That's the way I think of things, you know? If it's going to be benign and it's truly a nodule, the chances are it's going to be what? Granuloma, maybe a harmatoma that I don't see that often. But there are many things in the lung that look like nodules on imaging, but they're not even a nodule to begin with. Things like infarction, malformations. I'll show you a couple of pictures. So here, this is a granuloma based on biopsy, and you guys see this little thing right here with my arrows pointing? This is a what? Calcification. So in the lung, are calcifications in the lung usually a good thing or a bad thing? It's usually a great thing, but don't get me wrong. Calcifications in the breast, is that good or bad? Horrendous. Calcifications on the thyroid, good or bad? Horrendous. Those are called psammoma bodies when you talk about imaging. So you don't want calcifications anywhere else, but definitely in the lung, it's not that bad. So when we talk about harmatomas, these are what we call, based on imaging, popcorn calcifications. This is a harmatoma. They're very benign. They sometimes slowly grow. This looks like a nodule on CT, but in general, it's not a nodule to begin with. And this is associated with things like AV malformations. One syndrome is called hereditary hemorrhagic telangiectasias. This looks like, oh no, a mass, but it's not a mass. It's actually a disorder called pulmonary sequestration, which is like an accessory lung over there. So it's not even a mass to begin with. This looks like there is a nodule mass right here, but it's not. It's actually just rounded atelectasis. We see this sometimes with TB and asbestosis. And this looks like a huge mass, but it's not. It's huge calcifications. It turned out to be a pulmonary tuberculoma. So just because you see these nodule masses doesn't necessarily mean it has to be malignant, though it's scary to look at it. So when we think about a nodule, the keyword is a nodule workup. Well, how do we work up a nodule? I just keep it simple, is that our job is to put it in the category of, well, is it a low risk or is it going to be high risk as far as the chance of it being cancer? So how do I know that? I use two main things. Number one, the history. What parts of the history make me think it's going to be malignant? Older in age, Are you smoking? And a history of malignancy. So if you have those three things, the more you have, the higher risk. The second thing is always going to be the characteristics of the nodule. So when we talk about characteristics of the nodule, a couple things. Number one is that usually a lot of the ones we're talking about on boards and in the hospital or in the clinic are less than 1 centimeter. And the guidelines are going to be these less than 0.8 centimeter nodules. What do you do? So if you do see one, remember the best first initial thing to do with any nodule on imaging is always look at a previous image. That's your default, right? Because you want to see if you saw it back then. If you see a nodule on a chest x-ray and they ask you to characterize it, if they want you to use the words, is it stipulated, is it spiculated, is it laminar, you need to order a CT to really describe what the nodule is in most cases. And when we talk about low risk, well, chances are you're going to do imaging going forward. And well, there's very specific guidelines that they're not going to make you memorize it out, but as in broad strokes, usually we image for around 2 years, and if it hasn't changed in 2 years, it probably will be benign. But of course, there are very, very slow-growing lung nodules that grow after 2 years, and you have to be cognizant of that. If it's high risk, based upon the things we mentioned, well, you just can't image, right? You need to get what? Tissue. And in broad strokes for board exams, do we do the most invasive thing first to get tissue or the minimally invasive? Minimally invasive in most cases. Obviously, this is a discussion with tumor board and discussion with the patient. You lay out the options. But to keep it simple for board exam purposes, you probably want to do minimally invasive things first, depending upon the location of the nodule. If it's going to be peripheral in nature, probably a CT-guided biopsy seems reasonable. If it's central in nature, maybe my interventional pulmonologist can do their little EBUS stuff to get tissue. But it really depends, So when you look at my slide, low risk imaging, we're going to quickly show the Fleischner Society recommendations. High risk, you definitely want to get tissue. And the last thing is intermediate, so you could circle that with a red pen because there are patients, if they are intermediate risk, and the key thing is the nodule has to be greater than 0.8 centimeters. So if you could just highlight greater than 0.8, that will save you lots of headache because if you want to use your friend, the PET scan can only be used if it's greater than 0.8 centimeters in the lung, or else it's going to be way too small. And the PET scan is a scan that lets you know if you have metabolically active tissue, like cancer. It doesn't diagnose cancer, but it detects metabolically active tissue. And how do we do that? We inject a tracer called FDG. The G stands for glucose. And things that are metabolically active need glucose. So it gives you a PET scan superimposed on a CT so you could help localize. So PET CT scans will help out with these, well, is it cancer? Is it not? And the nodule is greater than 0.8 centimeters. Then you can use a PET scan to determine, do you want to proceed to biopsy or just stick with imaging? And that's a picture of a PET scan where you have the PET images down below. And this is the CT images up top, and they superimpose them. This is a tricky one. I think the best thing to do here is let's work it out together. Which of the following circumstances would a PET scan give the most useful clinical information in order to make a decision about going to surgery? So I gave you all these choices, and you could use a PET scan in all of them. But which one would it probably be the most useful? That's what it's really saying, right? So let's do it together because it's overwhelming. Would the PET scan be the most useful in a 45-year-old woman from Ohio who's never smoked and has a history of histoplasmosis and is now found to have a 2.5 centimeter pulmonary nodule on CT chest? And of course, no prior images are available. Is it useful in the 55-year-old guy who history of smoking, 2 centimeter left lower lobe nodule on CT? Is it good for the 58-year-old woman with a 3.5 right lower lobe, adenocarcinoma, so she has lung cancer, and she has, new neurological findings? What do you worry about then? Oh, man, that's going to be mets to the CNS. Is it going to be the 46-year-old woman with a 0.7 centimeter left lower lobe nodule and has a history of adenocarcinoma in situ that was resected 1 year ago? So what do we worry about here? Reoccurrence? Or is it going to be the 52-year-old poorly controlled diabetes A1C of 10.2 with a 60-pack history of smoking, and has an undiagnosed 3-centimeter right lower lobe nodule. Which ones would I probably, only in my opinion, would I not pick first? Which ones would I not pick first? I wouldn't pick D. Why is D going to be the wrong answer? Because it's only good for lesions in the lung that are greater than what? 0.8. So let's get out of the way. So I wouldn't pick D for test-taking skills. Which one would I not pick now? I am not going to pick A. Why don't I like A class? Because what does it really come down to? Is it an infection or is it what? Malignancy. Now, PET scan's good for what type of tissue? Metabolically active. So let me just ask you this. Are infections metabolically active? Yes or no? Yes. So does the PET scan determine what is infectious versus cancer? No. So wouldn't pick A, wouldn't pick D. So we're down to B, C, and E. So I wouldn't pick E. So I know, it's okay. It's all right. I said I wouldn't pick E. Everyone got constipated. Where is my lactulose? I don't know. You brought it. So the key thing is that it's not E based upon a couple words. It's poorly controlled. Because the tracer of a PET scan is what? FDG. And the G stands for what? Glucose. So if you have a high level of serum glucose, well, you know what? The tissue, the cancer will take up the serum glucose and not the tracer. You'll get a false negative. So if it was well controlled all the time, but just based upon the wording, I wouldn't pick E. So now it comes down to B and C, and I wouldn't pick C. I know. Bad Dr. Raj. So why wouldn't I pick C? Is because of the fact that, what are we looking for here? Mets. Mets where? The CNS, the brain. And what type of tissue is the PET scan good for? Metabolically active. And you know what defines a metabolically active tissue in your body? Are organs that don't need insulin to take up what? Glucose. So the two organs that don't need insulin to take up glucose are what? The brain. And that's why anytime you do a PET scan, it's going to be what? Positive. And that's why when you evaluate mets to the CNS, do you do that through a PET scan? No, you guys order what? Like CT, MRI, or one of those two. So the best one is always going to be B, which is a elderly gentleman, big history of smoking, and has a 2-centimeter nodule. 57-year-old man is evaluated after a chest x-ray is taken in a preoperative assessment for a knee replacement, shows a 1-centimeter nodule in the right lower lobe of the lung. Patient lives in Montana and has not traveled recently. He does not recall ever having been exposed to tuberculosis or having tested for the disease. His most recent chest x-ray was 10 years ago. The result was normal and the radiograph is no longer available. About 6 months ago, he had abdominal pain, went to the ER, got an abdominal CT, and the pain has resolved. The patient has a 20-pack year history of smoking, quit 10 years ago, and is otherwise healthy. On exam, vital signs are normal, lungs are clear, and there is no lymphadenopathy. Which of the following is the most appropriate next step in the management of this patient? Those are the choices. Do a quick once over on the choices. All right, and let's go. Here we go. Cool. So the reason why I put this question here is because this gentleman had like a 1-centimeter nodule in the lung. It was, oops, I have a nodule. And the rule number one for answering the board, and in real practice, is what do you want to do first is always look at previous what? Images. And I believe the nodule's where? It was in the right lower lobe. So it said the answer was the lung cuts of the abdomen, because it doesn't start exactly at the diaphragm. So yeah, you want to look at the previous image first to see if it was there or not. So yeah, awesome job, man. You guys are amazing. How about this 52-year-old woman is evaluated after a screening colonography, and oops, I found a 5-millimeter nodule. So, this is a virtual colonoscopy, and I believe you're doing GI after this. They'll talk about that for screening, And so they're doing a virtual colonoscopy, and they, found a 5 millimeter nodule in the right lower lobe of the lung. A tortuous colon prevented the full virtual colonoscopy. CT scan of the chest showed no additional nodules and was otherwise normal. The patient never smoked. She works at home, has never been exposed to potential carcinogens. She has not had a chest x-ray or other imaging procedure except a mammogram. Her medical history includes hyperlipidemia. She was on a statin. Family history is unremarkable. On exam, vital signs are normal. Exam of the skin is normal. No lymphadenopathy. Everything else is normal. So in this 52-year-old woman, I found the 5 millimeter nodule. Which of the following is the most appropriate next step in the management of this patient? And take a look at the choices. Cool. So this is when we talk about the Fleischner Society guidelines. I gave you the stuff in the slide deck, and it gets a little complicated when you start reading it out. And for the IM board exams for an internist, let's be honest, any nodule, any cancer, it's going to get presented in tumor board. It's going to be me, it's going to be a radiologist, a thoracic surgeon, oncologist, and we all debate all these things. And when we talk about the guidelines, the one guideline I would know is that if someone has a solitary nodule that's less than 6 millimeters and has no risk factors whatsoever, the guidelines recommend nothing, no follow-up. So good job, man. You guys are just amazing. So I put all the guidelines here. Please don't dwell on it because it gets really overwhelming. If you could just take your red pen and circle, this is for a solitary nodule, less than 6 millimeters, low risk. You get what? No follow-up. And they will never ask you to memorize this for a board exam because if I really wanted to know these guidelines, I take out my smartphone and I look it up. And so when we talk about management of other things, remember nodules don't always have to be solid. They could be ground glass, partly solid, or multiple. And I just put this here to make you realize no one memorizes all these things. The only one I've ever seen on a board question is the one that we went over today in class. Lung cancers are very simple. There are four major categories. There are two broad categories, and I categorize them traditionally into central and peripheral, though many people will say small cell, non-small cell. When we talk about central, the two classic ones are squamous and small, though they don't always have to be central. Peripheral tend to be adeno and large, but they don't always have to be peripheral. So I'm going to just throw a quick picture up here, and you could just do some audience participation. Just yell out what the diagnosis most likely is based upon just the image, and I'll talk about it. So here's the image. Patient comes in. Here's a chest x-ray. Here's a lesion over here. Here's a lesion on the lateral. We get the CT scan of the same patient. Here's a lesion over here. Here it is in the lung windows. Which lung cancer does this kind of look like? I'm not giving you any history or anything like that. Yeah, this is squamous. And why would I say that? It's because of one thing. It looks like this mass contains a what? A cavity. So squamous loves to cavitate. It just does. It's not the only one that does, but just loves to do it. So this is probably seen in smokers. It does tend to be a little more central, but doesn't always have to be. It loves to cavitate. It's associated with what electrolyte abnormality? Hypercalcemia because of parathyroid-like hormone that happens there. When you diagnose it, you're going to biopsy, and you'll see keratinization, when you do the biopsy itself. So this is squamous cell carcinoma. Here's a lung cancer. It looks like it's right here in the mediastinum. What cancer do you think this is most likely going to be? Yeah, this is small cell carcinoma. I guess a lot of you guys may have called this oat cell carcinoma in the olden days, And it's a neurosecretory tumor. It's derived from neurocrest cells, and it's very, very aggressive. It has a lot of paraneoplastic syndromes associated with it. Everyone's favorite is always things like SIADH, which is a very common thing to know about. It's aggressive. We don't use our classic TMN staging with this because it's so aggressive. We use the words it's extensive or it's limited. This is a horrible, horrible one to have. And the last thing I'll put down, once you circle SBC syndrome, it's centrally located. Any centrally locating tumor can give you SBC syndrome. If you have facial plethora or any of these things, you could think about an SBC syndrome. How about this, folks? Here's the X-ray. Here's the CT with the coronal. And here's some findings in the eye. This sounds like a what? Yeah, just based upon the chest X-ray, you would call this a Pancoast tumor. Pancoast was one of the radiologists that said if you have a superior sulcus tumor, that it's called a Pancoast tumor. This one was adenocarcinoma, but Pancoast tumors could be squamous also. And when we think about superior sulcus tumors, regardless if they're adenos or not, superior sulcus tumors do present with a couple of unique things. Number one is the eye finding, right? You call that a Horner syndrome, ptosis, meiosis, anhidrosis. And also, superior sulcus tumors can give you numbness and tingling of the hand because that mass could be associated with the brachial plexus. Good. And this last one is going to be a patient that came in and was complaining of cough and low-grade fevers and sputum production. So he was diagnosed with pneumonia, probably given Levaquin or something like that, and had initial imaging that showed this, poorly defined ground glass around the bronchivascular bundle. Maybe here's the air bronchogram or something. And they said, oh, it's probably pneumonia. Just finish your course of antibiotics, and let's get a follow-up imaging to make sure it gets, resolved. And of course, the patient didn't come back, but comes back almost 2 years later with persistent symptoms. We repeat the imaging, and the ground glass grew very, very slowly, and the patient never smoked. What lung cancer could this possibly be? So in the olden days, we used to call this bronchoalveolar carcinoma, but nowadays we call it adenocarcinoma in situ. And I always say it's very, very slow growing. Because it's slow growing, it tends to be PET negative because it's not very metabolically active. And, lung cancer is always bad, but for adenocarcinoma in situ, you don't always have to lop it out. Of course, to go for cure, take it out, but there's a lot of new data about radiation therapy and other things that we could do when we talk about adenocarcinoma in situ. And I think it's fair to put this here. Do we screen for lung cancer in the United States? The answer is yes. I would actually look at the bottom bullet points first before the top. When do we screen? Well, you got to have a greater than 30-pack year history of smoking or have quit within the last 15 years. And the ages, just memorize the ages, 55 to 80. So this is where we screen. And when should you stop? Well, I guess after 80, so that'll be 81. And if you haven't smoked in 15 years. And of course, the reason why we screen is because if you want to go for cure, you got to get surgery. So if you're not really a surgical candidate, then it doesn't really make a lot of sense to do this. And how do we screen for lung cancer? We do it with low-dose CT. We do it with a low-dose CT scan. So let's talk about pleural effusions, and that's going to lead my way to talking about tuberculosis right after this. So when we talk about pleural effusions, I started off with a chest X-ray because most of the questions in IM are going to start off with a chest X-ray and say, hey, what seems to be the problem? And so when I look at this chest X-ray, I would say that there is actually a density where? A density right here. This is going to be in the right middle and lower lobe. How do I know the right middle lobe is involved? Because I don't see the right atrial border. I know the right lower lobe is involved because I don't see the diaphragm. And then the question, and I do see on the lateral this nice retrocardiac density. Then the question becomes, well, what could this density be? And then is it going to be effusion or consolidation? And the way you're going to tell is by ordering some testing. They may ask, what test can you order to confirm it's an effusion? So I think classically, we'd order a lateral decubitus film where someone lays on their side and you look for that layering of fluid. But then I always do a follow-up and say, is it possible you do a lateral decubitus and there is no layering of the fluid, and can it still be an effusion? The answer is what? Yes, it could be loculated. Other things you could do is a CT scan of the chest, but remember, CT is somewhat invasive, and usually a CT would be more helpful after you drain the fluid so you could look at the underlying parenchyma. The last thing you could do would always be ultrasound. And I would say that's my default answer on boards. It would be, is there an ultrasound you could do, whether it be yourself at the bedside or ordering a sonographer there? Because not only can you do an ultrasound for diagnosis, you could do it if you perform a thoracentesis. So, but remember, the images will first start off with chest x-ray and say, you have to confirm it's a fluid. Think about things like ultrasound, which is this picture over here. Here's this huge anechoic area where it looks very, very, very black. You could do a CT, but remember, it may be more helpful after you drain the lung, but here's the same fluid in the same individual over here. And when we think about fluid in the body, anywhere in the body, the question now becomes, well, what caused the fluid to be there? And when we talk about pleural effusions, you want to put it into two categories. Is it a transsudate or exudate? And we do what's called Light's criteria. Light's criteria is up there. It's going to be the pleural LDH to serum, total LDH, and the pleural effusion to serum protein ratio. And the key teaching point is, if you want to be an exudate, how many of Light's criteria need to be positive to be an exudate? And the answer is 1. To be a transsudate, how many of Light's criteria have to be negative? All 3. So if you use those evil biostatistic terms, Light's criteria for a transsudate is very what? Sensitive or specific? It's specific. And the reason why it's so specific is no one dies from a transsudate per se, but for exudates, if you only need 1, it's very sensitive. Because what are the 2 most common causes of an exudate? Infection and malignancy, infection and malignancy. And you definitely don't want to miss those things, and that's why it's very, very sensitive. So I listed some transudative things, and so I think the things to remember, it's things that mess up what you call Starling's forces, hydrostatic and oncotic pressure, so CHF, nephrotic, cirrhotic, other things that can do it, atelectasis. And if you could take your red pen out and circle pulmonary embolism, it can cause a transudate. For exudates, I just would know the top 2, infection and malignancy. But look at the second bullet point. What does it say here? PE, and I think everyone in class knows that PE is kind of a tricky one. It can present both as a transudate and exudate. So when we think about when do we put in a chest tube, obviously we think about it for exudates, more like if you're going to have nasty pus like empyema. So if you have a positive fluid culture on the pleural fluid, they use the words complicated, loculated, you may want to consider putting in a chest tube for a variety of reasons. So I put those bullet points up there on this slide. So when you get the pleural effusion, obviously they're going to give you chemistries of what you ordered and what you need to evaluate. And so the ones that I really would circle with your red pen, if you could circle lymphocytes and neutrophils, the answer is you always want to get a CBC to know the diff, because it's huge if it's a neutrophilic exudate, bacteria chances are. If it's a lymphocytic exudate, that's messed up. And what is the 2 main differential for a lymphocytic exudate? It's cancer and TB. And that's where you really want to know what the workup is going to be, because it's a little bit different when we talk about pleural TB. Obviously, not everyone gets a pleural biopsy. It's very, very barbaric. You know, we'll do things like AFB. Everyone loves a good ADA, adenosine deaminase. So there are certain things we do when we think about if it's going to be pleural TB. Other things I would circle, glucose. Of course, check serum glucose first, but if it's very low, something bad might be happening in the lung, like an empyema, but you would probably see pus coming out if it was going to be empyema. One of the buzzwords in many board review books is that a rheumatological effusion, like associated with rheumatoid arthritis, tends to have a very, very low glucose and low pH. It almost mimics an empyema, but it's not pus. And those are the main ones I would think about when we talk about pleural effusions. This is, I think, a really good question. It's a 62-year-old male, has a non-productive cough, weight loss of 20 pounds over the last 3 months. He has noted a hoarse voice for the last month and had a 50-pack year history of smoking. He only quit recently. On exam, his BMI is 19, auscultation has decreased breath sounds, dullness to percussion, prolonged expiratory phase, has positive ergophony, that E to A, decreased tactile firmness when you do the 99s, and the remainder of exam is unremarkable. So those physical findings are consistent with effusion, by the way. So they do a CT scan, and it shows a pleural effusion. If you want to look up here, here's your pleural effusion.
And here's the mass over here. And what do you think probably caused this pleural effusion in this person? It's probably going to be cancer, right? He smokes and weight loss and all that kind of stuff. So as they should, they did a diagnostic thoracentesis. They got 100 mLs and lymphocytic exudate. Yuck. And they did cytology on it, and negative for malignancy. Okay, sounds like a classic board question. Which of the following is the most appropriate next step in the evaluation of this patient? So can you just take a look at the choices? And here we go. Oh, all right. So when we do this, things that I would just not pick, I agree with everyone. I wouldn't PET CT scan because you didn't make a what? Diagnosis yet. You don't really want to stage just yet without doing it. So this is great. Closed pleural biopsy, that is a little barbaric. We do it at the bedside, and we go there with these ancient things called an Abrams needle or a Cope needle, and I don't even want to think about it. And I only do a closed pleural biopsy when I think about what pathology in the pleural space. Pleural TB, right? This closed pleural biopsy is blinded. I just put that needle anywhere, and I just try to get blinded biopsies of the pleura. So that's usually when it's pleural TB, because pleural TB coats the whole pleural space. So you could go almost anywhere and get the diagnosis. Does anyone think this is going to be pleural TB? Probably not, right? So it really comes down to, are you going to do a scope or are you going to do a thora? So when you look at this over here, remember, anytime we talk about any patient who has cancer, suspected cancer, the two most important things is, number one, of course, get tissue. And what's the other most important thing? Staging. And when we stage any cancer, how do you want to stage it? To the lowest stage or the highest stage? The highest. You want to say who's going to be going for cure and resection and who's not. So if you do an EBUS, everyone, you're going to come down here with your scope and you're going to needle this primary mass. If you needle the primary mass, what stage would it be? Stage 1. But if you were actually to make the diagnosis in the pleural fluid, what stage would it be? 4. So that's one reason I would pick it. Number 2 is going to be when you do a thoracentesis for cytology, the chances of getting the diagnosis on the first shot is somewhere around 65% or so. If you just repeat it, it goes up to like 80, 85%. If you do it 3 times, maybe up to 90%. And of course, think about your patients, which will probably be the easiest thing to do is just doing a simple what? Diagnostic thora. So the answer is going to be thora. Good. Excellent job, everyone. So I wanted to mention Pleurx catheter because I know many of you guys do Pleurx stuff. And the big thing about it is that it used to be only for malignancy, but it's scary. It got FDA approval for what? CHF. Ugh, horrible. So now many people are trying to put these Pleurx catheters. They're tunneled catheters where you tunnel through the skin and you leave the catheter in there. We still mainly use them for malignancy. Truthfully, if you choose the patient appropriately, I love Pleurx catheter. It causes a pleurodesis in itself by leaving the catheter in there. Obviously, you have to have good insurance and family support and all these things put together. But I do put a lot of Pleurx in well-chosen patients. The second bullet point has data that says now what we're doing is not only are we putting in the Pleurx catheter, we could inject it with maybe a sclerosing agent to help with the pleurodesis also. Now let's talk about latent and active TB. Still amazing how many questions are on this for board exams. So TB is caused by disease called Mycobacterium tuberculosis. It's spread from person to person through the air. And I would say this, it's not like Neisseria meningitis, where if you're just vaguely around the person, you're getting prophylaxis. When we talk about TB, you really, really, really have to be close to that patient in close contact. So most people get TB. Who gives it to you? Your family members, your relatives, people you love, you know what I mean? Because you're always going to be around them. It's not that easy to get TB. And when we talk about TB, the most common organ involved is always going to be the lung. So we call it primary TB or pulmonary TB. But TB can affect every single part of the body. It kind of sounds like what? sarcoid, So when we talk about TB, it usually goes to places that have lots and lots and lots of oxygen. That's why it loves the apices of the lungs. That's why it likes the central nervous system like Pott's disease. That's why it likes the adrenals, places that really need lots and lots and lots of oxygen. But the key thing is, how is your immune system, right? If your immune system is good, it's not a big deal because anyone who's infected with TB gets two choices. They could have latent or they could have active. It really depends. So when we talk about latent TB, number one, what are the patients going to present like? Nothing. They're going to be asymptomatic. That's the most important thing. And because they're asymptomatic, the only way to decide if they're going to have TB or not is to perform these tests that we're going to talk about, things like a PPD, things like an interferon gamma release assay. And it's very important to realize that when we talk about people who have latent TB, that they're truly, 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 truly not infectious. So if you're sitting next to someone who has latent TB, don't hesitate to give them a big hug. It's okay. Don't do that. So the key thing is that they're not infectious. So when we talk about how do we screen for latent TB, I think the classic thing is always going to be a PPD. We still do that. And when we talk about how to read it, well, obviously there's a lot of reader bias, but you want to do a follow-up in around 48 to 72 hours, and you want to look at perpendicular to the axis of the arm. And it's not about how red it is, it's about induration, right? So you really got to feel it out to determine if it's going to be positive or not. And when we talk about what constitutes a positive test, well, there's always going to be CDC guidelines of what are your risk factors depending upon the size of the induration. So one thing I always wanted to mention with any of these screening tests for TB, it's always going to be clinical suspicion. Was there risk of getting it someone who was in a high-risk patient or a low-risk patient? And of course, you never want to screen a PPD or an interferon gamma release assay in someone symptomatic. If they're symptomatic, you're going to be looking for TB, not screening for it. So I put down the CDC guidelines of what constitutes a positive test when we talk about the millimeters of induration. So I kind of bookshelf them between 5 and 15, which is 1.5, and 10 millimeters is everything in between. So if you're positive at 5 millimeters, who is that? Well, people who are going to be HIV positive. People who are going to be immunosuppressed are going to be positive at 5 millimeters. 15 millimeters are people who are asymptomatic with no risk factors. You really have to have a huge induration to be called positive. But everyone else, and this is what we truly, truly care about, this is everyone in this room, healthcare workers, diabetes, 10 millimeters is 1 centimeter. So if you have it greater than 1 centimeter, then it's going to be positive. So I put some kind of like buzzwords in here. Well, who should be tested in general? The key thing is if it's latent TB, you have to be asymptomatic, but you're at risk. Asymptomatic, but you're at risk of getting TB. What's a positive test? I already listed those out. The 5 millimeters and 15 millimeters are the bookshelf. Everyone else is going to be 10 millimeters in the middle. So I want to spend the most time with this slide because people tend to ask me a lot of this question, which is fine. What does it mean to be a new converter and this booster? So when we talk about doing a booster, that's a 2-step PPD. And who gets 2-step PPD are people who get PPDs annually. And who will get an annual PPD? You and me. So the General Society doesn't do a 2-step. So everyone always asks me, why do we do it? So when I first started working at USC, I had to get a PPD, and it's negative. Then 2 weeks later, they made me come back and get the PPD again. Why do we do that? To establish a baseline. Why do we want to establish a baseline is because anytime you get a PPD, let's say they only did a 1-step on me. I go there, they do it, it's negative. Then they send me to the wards. And let's say 3 months later, I'm exposed to someone with tuberculosis. And then I turn out to be PPD positive. Well, what does that mean? It means that, well, maybe I was exposed to someone with active TB, or it still could be the what? The booster. Because people tend to forget the booster lasts for months and months and months. And why does it make a difference is because it's about prognosis. So people who have latent TB, the chance of, if you're non-HIV positive, the chance of going to active TB is around 10% of your lifetime. But 5% happens really when? the first 2 years. So it's because if you're a recent converter, those are the ones that we're really aggressive about treating. Because if you're already older in age and the chances of getting active TB is much, 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 much less, which is why we don't have to treat everyone for latent TB once you get a certain age and you're pretty healthy with no risk factors. So it makes a difference. So why do we do a booster? To establish what? A baseline. That's the whole purpose behind that. So when we talk about some other buzzwords for the boards, what is a treatment for a positive test? I'm going to have a slide in about 2 to talk about all 4 treatments recommended by the CDC. But I think most individuals will always think INH for 9 months, you know? And let's just be honest. Let's call a spade a spade. Does anyone take the drug for 9 months? No. So it's not very practical, side effects, you know, but yes, that is the classic thing that we think about is doing 9 months. Who should be treated for latent TB? Well, the answer on the boards is pretty much everyone, but that's very controversial because I just said that in non-HIV patients, it's really the first 2 years that has that 5% chance of developing active TB. If you're HIV positive, well, that's going to be a 10% chance of getting active TB per year, so it's going to be much, much, much different. The fourth bullet point is always what happens if you receive this vaccination called the BCG. Nowadays, the answer is it doesn't mean anything because even though the BCG could have given you a false positive PPD, all you need to order is an interferon gamma release assay. You guys call that a quant gold or something. And that really has no effect of getting the BCG. So it means nothing now. We just would do what we call I refer to as an IGRA, interferon gamma release assay, an IGRA. And the last is, when is anergy testing the answer? And the answer is never. And people ask me, what is anergy? So in the olden days, in the 1990s, HIV, big thing, that what happened is if we do a PPD, and it was negative, well, how do we know it was really negative? Because in HIV, it's a disease of your CD4 cells. And when we talk about a PPD, it's a type 4 delayed hypersensitivity reaction that needs lymphocytes. So what we would do in the olden days, don't do it now, is that we would do a PPD and also do an inoculation with a known virus. And so if the virus causes a skin reaction and the PPD was negative, you could truly say it's negative. But if the virus didn't cause a reaction and the PPD is negative, you can't truly say it was negative. But nowadays, it's so much easier because if you're HIV positive, I won't give you a PPD. I'll just do a what? An IGRA, because it's not affected by it. Very good. So when we talk about these IGRAs, there are 2 of them out there, Quant Gold, and there's a new one out there called the Quant Gold Plus, you know what I mean? And there's always the T-spot that everyone's like, heard about it, but they've never seen it because it's not common to do a T-spot. But these are the 2 IGRAs that are going to be out there. So Quant Gold, the classic one, has been around since 2005. And the good thing about it is the results, positive or negative, but then of course everyone always gets bummed out when it's intermediate because what do you do next? You know, it all depends on clinical suspicion. You could repeat the test, or many times you will do this test instead, the T-spot. FDA approved in 2008, very lab tech dependent. It's called a T-spot because you're counting spots on a well. And here's what the patients look like. The techs will do is they'll count how many reactions on these well spots. The more spots you have, the more positive the result. The less spots you have, the more negative. And of course, we take both the Quant Gold and the T-spot with the history and the physical. So I like this slide the best because I combine the Quant Gold and T-spot together. So what are the advantages of doing this? Both of them, patient does need to come back for a second reading, which is nice. Supposedly they're available within 24 hours. That never happens. There's no booster phenomenon, which is nice. You don't have to worry about the 2-step testing. There's no reader bias. And the big things are the bottom 2 points. It doesn't matter if you got the BCG, and it's not affected by patients who have HIV. So when we think about latent TB and treatment, I always say, is it ever an urgency to treat for latent TB? And the answer is what? No. The most important thing is to rule out what? Active TB, because you'll feel really bad if you treat for latent and you start developing resistance. That's what you worry about the most. So I put the 4 CDC-approved regimens for latent TB. INH, always want to know side effects. INH gives you some neuropathy. That's why you do take some B6. INH loves to cause liver issues, but I don't see it that commonly. But it's very important to be involved with your ID doctor and the Department of Health. They'll do little things like maybe they'll hold your statin for a while you're on INH. So important things like that. 6 months of INH is CDC approved, but we don't prefer that. You're going to get better resolution, but let's be honest. Can you still develop active TB after you're treated for latent TB? Yes, but the risk is so much less, and you have better efficacy if you go all the way to 9 months versus 6. 3 is 4 months of rifampin. And, sure, that's great. But rifampin is a really hard drug to take. And I don't think anyone really appreciates it till you have a patient taking rifampin. It's very nauseating. It causes vomiting. No one really cares about the orange-red urine. It's really the nausea and vomiting it causes. And rifampin is the workhorse for active TB. And if they can't take the rifampin, there's no really any point in getting the other meds. So it sounds cool, 4 months, but it's really hard to take rifampin. I like the fourth one quite a bit. It's a 3-month regimen where it's a combination of INH and rifapentine, and you take him once a week for 12 doses. It's really good because of the fact that compliance, it does say it's DOT, directly observed therapy, though no one ever does it. But the only problem is rifapentine, I don't know if your patient's been on it, it's super expensive, it's not covered by insurance. Your patients will get pretty upset by that. But that's the most practical one, and that's the one I use. My wife uses it too, so if you don't know, my wife's actually a rheumatologist. So she gives out a lot of steroids and lots of TNF inhibitors. So we use this one quite a bit in our patients so they could be on drugs like TNF inhibitors. Well tolerated. So latent TB facts, couple things. Number one is that you don't want to get resistance. That's why you have to rule out active TB. And of course, I put down some terminology. Multi-drug resistant means resistant to INH and rifampin. Thank God we don't see a lot of extensively drug resistant or totally drug resistant TB in the United States. This vignette's supposed to be pretty straightforward because I want to go to the teaching points. Homeless man comes in, 39 years of age, fevers and weight loss, non-smoker, febrile, thin, unkept, temporal wasting, there was a mobile cervical lymph node, and the cardiopulmonary examinations are normal. Differential diagnosis in someone like this, of course, is it active TB? Is it going to be lung cancer? All these things are in a differential diagnosis. They do some imaging, and I just put some of the imaging right here. You can see cavitary lesions in the upper lobe. In someone like this who's homeless, oh boy, this is TB, no proven otherwise. So how do we manage these patients? Protect yourself, protect others, isolate. And I want to talk about what do you do with the sputum. So anytime they come in, you want to get sputum, right? And we always send them for the big 3. What are the big 3? Number 1 is going to be AFB stain, otherwise known as a what? Smear. And we send it out, but no one ever actually does it. That's why you never see it. The stain and smear should be looked under a what? A microscope immediately by a lab tech, because if you're stain and smear positive, that means you're very, very what? Infective. Then if you want, the second place you want to send the sputum is where? Mycobacterium TB PCR. So if you want to diagnose TB instantaneously, you need 2 things. PCR and AFB positive, there's no questions asked, that's going to be TB. The third place you're going to send the sputum to is the AFB culture. Now, when we think about growing TB, does that happen overnight? No, TB is a super, super, super slow grower. And of course, there are many people who could be smear negative, culture positive. There are many people who could be smear negative, PCR negative, and culture positive. So it really depends on your clinical suspicion about what's going on. So when we talk about how do we treat these patients, the memorizing thing is you do 4 drugs for 2 months and you do 2 drugs for 4 months for a total of 6. But let's be honest. If I had to treat these patients, I would get the department. Well, you have to report them to the Department of Health anyways. They have very smart doctors. They'll take control of the case. Usually ID manages them for me. And the big thing is that even though we say 4 drugs for 2 months, it doesn't usually pan out like that. Why? Because you want to send for sensitivities. So if you have a very pan-sensitive TB, the workhorse is always going to be rifampin, and there's some INH. Of the big 4 drugs given initially, which one does the least? It's ethambutol. Ambutol is only going to be there for what? To prevent resistance. So the minute you have pan-sensitive TB, they'll take out the ethambutol probably in the first week if you get sensitivities. Then they'll keep you on the parasitamide. And remember, I don't know if you guys have patients with active TB, it's really painful. They have to take 14, 15, 16 pills. So it's really, really tough to take all these. They're so nauseating, especially the rifampin. I feel bad for them. And then at the end, they'll take INH and rifampin for 4 months for a total of 6. So active TB, mean it's still one of the leading causes of death outside of the United States worldwide. And of course, we see this because of HIV. TB can go anywhere in the body, though lungs are always going to be the most common. That's a picture of the spine in Pott's disease. And what can TB do in the lung, everyone? Well, it's very destructive. So I showed a very destructive picture here. It can cause hemoptysis. It could cut the cavitaries, could rupture and cause pneumothorax. It induces a bronchiectasis. So all these things could happen. It's a very destructive lung disease that causes architectural distortion in the lung. So I really like these slides I put here for you folks. Why? Is because, nowadays it's not just about TB in America, it's about NTB, the non-tuberculous TB, right? What do we do with these patients and how do we work them up? So I made this very simplified to say, when you even suspect it, it's based upon the clinical, imaging clinical, that's when I suspect it. Once I suspect a non-TB mycobacterium, then I gotta diagnose it. I diagnose it in 3 main criteria. Can you give the sputum? And I need to have 2 separate cultures positive for this non-TB. Or I could do 1 bronch and 1 positive culture from a bronchoalveolar lavage. Or if I'm biopsying when I'm in there by coincidence, 1 biopsy. So all those are the microbiological criteria to diagnose non-tuberculous TB. So let's go back to these sputum. Someone comes in, I suspect some type of TB or NTB. What do? I said I get the sputum sample. What do I do first? I get AFB smear. And if the smear is positive and the MTB is and the TB is positive, that's tuberculosis, end of story. But if the smear is going to be negative, what do I have to wait for? The culture. If the smear is negative, I got to wait for the culture. And what do? We put the culture in one of 2 categories. Does it grow before a week? It's called rapid grower. If it grows after a week, we call it slow grower. So what happens is that if the culture is positive and within a week, we call the rapid growing, and there are certain bugs like Mycobacterium abscessum, all these nasty things that it could be. If it's going to be a slow grower, well, I don't really have to wait till it grows out because we only have 2 PCRs available for mycobacteria. We have a PCR for TB, and we also have a PCR for MAC. So if it's going to be a slow grower, I could drop the PCR probe, and if it's MAC, sure, it's MAC. If it's negative for that, I just have to wait for it to grow, and I love to grow it, and I love to get susceptibilities because it really dictates my management. So why did I mention this? Why am I telling you about a rapid-growing mycobacterium versus a slow-growing? Because of the fact that it does change what we give empirically for antibiotics. Rapid-growing, the big one we always think about is abscessum. For slow-growing, we think about MAC. And when we think about how does it affect my antibiotic choice, that's what this is that rapid-growing mycobacterium are usually resistant to TB therapy. Non-rapid growing, which is a slow growing, are usually resistant to conventional antibiotics, which is why if someone has MAC in their body, you kind of don't want to give them macrolides because that's really the workhorse, right? We give them a lot of like clarithromycin stuff. So you want to be careful what you're treating. It does affect that. So that's the thought process in this section of the notes about mycobacterium. So now let's talk about PE and DVTs. So when I talk about PE DVTs, they're kind of clumped together, everyone. And needless to say that PE is still the 3rd most common cause of cardiovascular death after stroke and heart disease. And remember that when we think about PEs and DVTs, that we're treating a lot of these as outpatients. We just are. And that's why they're asking a lot of questions on board exams. When we talk about PEs and DVTs, we are also seeing a lot of DVTs in the upper extremities. We are, you know what I mean? Why? Well, in hospital, many of my fellows are putting central lines and Swan-Ganz, dialysis catheter, but we're also seeing a lot of upper extremity DVTs in what patients? Does anyone know? Athletes. We're seeing a lot of them in athletes. In fact, I'm from LA, I love the Lakers. One of my starters of the Lakers just got taken out for the whole season because he developed a DVT in the upper extremity. And how do athletes get upper extremity DVTs? Thoracic outlet syndrome. Because they're using their arms and shooting so much they hypertrophy the muscle, and it squeezes what? The veins. So we do see a lot of upper extremity DVTs nowadays, So when we talk about DVTs and PEs, the question as an internist is always going to be, why? Why did you get it to begin with? Because we put DVTs and PEs in two broad categories, from a known cause or an unknown cause. Some of you guys call that reversible or non-reversible, or provoked or non-provoked. So you always want to look at the risk factors of why they clotted to begin with. I listed a lot of them out here for you folks. Pregnancy, smoking, birth control, of course. Birth control, estrogen, that's the nasty one, right? Also think about SERMs, select estrogen receptor modulators. Things like tamoxifen or aloxafen can also do that. Nephrotics tend to clot. And why do they clot? Because that Bowman's capsule, it's non-discriminatory. You'll dump out all those proteins in the urine, including what? Protein C, protein S, and antithrombin 3. So they definitely tend to clot. And I think a buzzword for board exams is, where do nephrotic patients tend to clot the most? And the answer is that renal vein, right? So always think about renal vein thrombosis in nephrotic syndrome patients. Of course, perioperatively. And if you could look at the second column over here, folks, common things are common. What are some big risk factors for PE and DVTs? Diabetes. It just is, man. Older in age. Those are big things. Obesity. So you definitely want to look at the risk factors. Other risk factors I put here for you folks, cancer. Especially if you're an older individual and you clotted for no reason, you'd have to think about malignancy. And we don't do a very extensive cancer search. We don't order all the tumor markers for no reason. We do what's called age-appropriate screening. But obviously, if they have very specific symptoms, then we order very specific cancer markers and evaluation. Hypercoagulable workup is going to be on this column over here. And I think that the rule of thumb is that all of us, including myself, tend to over-order the hypercoagulable workup. It always frustrates the hematologist quite a bit. But what is the hypercoagulable workup? It's a bunch of genes that predispose you to clotting, protein deficiencies, maybe some antibodies, and some homocysteine. But these are things that are very, very uncommon. And why do people say we use it too much? Is because if you work them up and they never clotted, well, then you shouldn't put them on anticoagulation if they never clotted. And if they clotted twice already, well, why do you need to work them up? Because by definition, they're going to be on lifelong what? Anticoagulation. So when do I really think about it is if they're young at age, family history of having clotting, or I always say if you clot in a funky place. So everyone always asks, what's a funky place to clot? Hepatic vein, portal vein, splenic vein. Clotting in the artery, that's odd, you know what I mean? So if you clot in a weird place, you may want to do a workup. So what are the ones they ask you on the board exams? They're over here. So if you're going to have a hepatic vein thrombosis, you guys call that a Budd-Chiari, or if you have like a portal vein, well, yeah, they said maybe you order funky things like polycythemia vera workup, get that JAK2 mutation going. Maybe you'll work them up for PNH. You get that CD 55, 59, if it's a weird place, I like the second bullet point where someone has a clot, you put them on warfarin and they get skin necrosis. That's not good. So you check for protein C deficiency. And clotting in the artery is never normal. So maybe one of the clotting disorders associated with that is antiphospholipid antibody syndrome. And remember, when you order a lot of these protein levels, you want to make sure they're not actively clotting because these levels will be low, or they're not on drugs that will cause these levels to be low, like Coumadin, because Coumadin works by inhibiting protein CNS also. So of course, they'll be low with those things. So when we talk about DVTs, everyone, they keep it very simple for the IM board exams. All DVTs, thank God, are where? The lower extremity. So that's what we're going to be talking about. So in the olden days, we used to talk about the gold standard being venography. No one orders it. Please never order it. It's not practical. When we talk about DVT of the lower extremity, think about D-dimers. I think D-dimer is usually helpful for outpatients. It really, really is. We all tend to use the ELISA nowadays. And D-dimer is really based upon your pretest probability. And when do you want to order it is when someone has a very low pretest probability. You don't want to do it when it's moderate to high because you'll be looking for the clot. And so that's why when is the D-dimer going to be helpful is when the results are what? Negative. And that's the key thing you want to look for when we talk about D-dimers. So for the lower extremities, ultrasound by far is the go-to answer on the board exams. You want to look for the lack of compressibility, look for the clot itself. Maybe you could have some Doppler. So definitely ultrasound would be my go-to first initial diagnostic test. And then I put a fun question. You could just raise your hand. Lower extremity DVTs, folks, if I were to poll the entire world, where do most people have most lower extremity DVTs? On the left or right lower extremity? What do you guys think? Who says it's going to be in the left? Cool. Who says it's going to be in the right? Cool. So the answer is always going to be the left. Why? It's because the left iliac vein needs to transverse a longer course to get where? To the IVC. And sometimes the left iliac vein, sometimes it may get pinched in between the spine and the left iliac artery. And if you pinch the left iliac vein, what happens to blood flow? You get stasis, right? And you're predisposed to clotting. And when you have pinching of the left iliac vein, there's a very specific syndrome you have to memorize. Does anyone know what syndrome that is when you have pinching of the left iliac vein? Yeah, that's what they call the May-Thurner syndrome. So that's only a little board pearl for your board exams. There it is, May-Thurner. So if you want to diagnose a PE, folks, how do we do it? I just put down a lot of different tests. I'm going to talk about each one briefly, but we'll do a summary at the end. So if you want to diagnose a PE for sure, could you do that only based upon an ABG, yes or no? The answer is no. I wouldn't treat anyone for a PE based on an ABG. What do you usually see in most PEs, the small ones? They'll be a little tachypnic, right? They'll probably have a low CO2, so they have like a respiratory alkalosis. They have a widening of the A gradient. So, but it's just not enough information to diagnose anyone with a PE. How about chest X-ray? Could you 100% diagnose a PE only based on the chest X-ray? The answer is no. And what is probably in Boardland the most common chest X-ray finding in the PE? The answer is pretty much normal, right? You could get maybe some atelectasis, maybe you could get some small effusions, but essentially it's normal. Once in a while, you could see these classic findings. And what names am I thinking about? Hampton's hump, Western mark sign. And let's look at a couple of these things. So Hampton's hump right here is a infarction of the lung. And you just know it's such a pain in the butt to infarct the lung because of multiple blood supplies that go there, so we don't see much infarction. But in the right clinical setting, we call this a Hampton's hump. Western mark sign is a pulmonary cutoff sign where you could have a pretty big PE, but on chest X-ray, you notice that there's a lot of markings over here, but on this side, there is a lack of markings. They call it the Western mark sign. But I wouldn't diagnose PE based on any of those things. This is a classic one. I know you all know this, but on EKG, would you diagnose a PE based on that? No way. And what is the most common finding on EKG if you have a pulmonary embolism? The answer is sinus tachycardia. One of those trick questions, But everyone loves to say S1Q3T3, and that's cool if you see it, And what does S1Q3T3 mean? Right-sided heart strain. People with PEs can get right bundle Blanche-Brock, right axis deviation, right ventricular hypertrophy. So it just means a right-sided heart strain is what you can get with S1Q3T3. VQ, that's always a spicy one. Would you anticoagulate someone based upon the results of a VQ scan? What do you think, guys? Yeah, I would. I would anticoagulate someone, of course, based upon the history and physical. And remember in the olden days, it was kind of like, what did we say? Get a chest X-ray first. If it's normal, get a VQ. But nowadays, we don't really do much VQ because everyone gets a what? CT. And that, of course, is the most accurate non-invasive test. VQ scans always get us frustrated. Why? Because the reasons are it's low prob, medium prob, very little prob, and you're like, what? So you always have to take the probability with the history and physical of what you want to do. But definitely, the only time nowadays we do VQ scans is if you can't do a CT, and the only time you can't do a CT is if you can't give the what? The contrast. And those are the times that we use VQ scans with, but I definitely would anticoagulate given the right history and physical. One thing I put this here for is that in the acute setting, once you diagnose a DVT, you pretty much diagnose the what? a PE. So only in the acute setting, when you can't bring the patient down to the CT scanner, like for a variety of reasons, if you diagnose a clear DVT, you're going to anticoagulate, so it doesn't change your management. Chronically, it definitely does. You do want to prove that PE for a variety of reasons, but acutely, once you diagnose a DVT, you diagnose the PE. CT angio, this is the one everyone loves, you know what I mean? And CT angio, if it's safe to bring the patient down to the CT scanner, you have to be supine, you have to hold your breath. All that sounds really painful if I had a big PE. And what study answered the question that CT is the gold standard non-invasive test? It's called the PIOPED-2 study. And it compared to all different modalities of evaluating PE, including VQ scans and ultrasounds of the lower extremity and all these things put together. So that's why the non-invasive gold standard is a CT angiogram. So how about a true false for everyone? Majority of patients with a PE identified by a CT scan have negative leg ultrasound. Okay, that's an interesting one. Kind of a tongue twister. The answer is true. So what happens is that the way I look at it is like this. So if someone comes in and says, hey, I have some chest pain over here, and I do an ultrasound because of whatever reason, and it's negative in the ultrasound, did that rule out a PE? No. But if it's positive, do you have to order a CT chest acutely? The answer is what? No. Good. And echo, I mean, everyone's doing bedside echo nowadays. It's great for my pulmonary critical care fellows. When someone comes in shock, is there a tamponade? Is there other things? But, you know, I cannot diagnose a pulmonary embolism solely based upon an echo. There could be classic findings, but you can't make a 100% diagnosis. And the invasive gold standard is the pulmonary angiogram, which we rarely order. We can do it for chronic PEs for other reasons. I'm not saying we don't, but in the acute setting, no one should be getting a pulmonary angiogram in the acute setting. You do a CT angio instead. So this is going to be a transition slide to treatment. Can you treat a pulmonary embolism patient as an outpatient class? Is that a yes or no answer? By far, yes. Obviously, there are people who are very sick. We have different scoring systems to say who needs to get admitted. But the rule of thumb is most people with DVTs, most people with PEs, they get treated as an outpatient, which is why it's so important for internal medicine board review. So let's do 2 questions about management. 26-year-old male is evaluated in the ED for 24-hour history of swelling of the left leg and calf. Medical history is unremarkable, but he reports his uncle had a DVT. He takes no meds. On exam, a febrile normotensive, non-tachy, non-tachypnic. Swelling of the left lower extremity is noted, and a dorsiflex of the foot elicits pain. I think many of us call that a Homan sign. Doppler ultrasonography confirms a left lower extremity DVT of the popliteal vein. Popliteal vein is a deep vein. Based on the ACCP guidelines, which of the following is the most appropriate initial management? So take a quick look at those, and I'm going to press the button. Yeah, and you know, a lot of these are just kind of like, if you chose A, you missed the bus over there. It's not prophylaxis. We're not going to give a lytic in this patient, which is C. And, giving warfarin without heparin product first, that sounds like a bad idea, right? So this is going to be when we talk about the factor 10A inhibitors are out there. So great job, Xarelto. So 28-year-old man is evaluated in the ED for a 24-hour history of swelling of the left lower extremity. Medical history is non-contributory. He takes no meds. On exam, a febrile normotensive, non-tachy, non-tachypnic. Pulses are intact. A swollen left calf that's slightly tender to palpation. Labs, a PTT of 32. Great. platelets are awesome, INR of 1. They do an ultrasound, and there is a DVT in the left popliteal, and it goes all the way up to the iliac vein. The patient expresses significant concern about anticoagulation in general, mainly because he had an uncle that was on some kind of anticoagulation and had a cerebral hemorrhage. Well, that stinks. And so he's concerned he's going to get a cerebral hemorrhage also. So according to several trials and treatments of DVTs, which of the following is the most appropriate treatment option for this patient, given the concerns about the hemorrhage of the CNS? All right, here we go. Yeah, I think that B and C, this is not a case for antiplatelet medication. I think it really came down to who wants to do something traditional, low molecular weight and Coumadin versus a factor 10A Eliquis, And the answer is many studies were comparing the new oral anticoagulants and their risk of bleeding. And we really care about bleeding into a vital organ. And the two vital organs that all the studies really surrounded by is the most common organ we bleed into, which is what? GI, and the most detrimental organ we bleed into, which is what? CNS. So now we're talking about the CNS. And what the data showed was doing traditional therapy with low molecular weight heparin and Coumadin versus these new oral anticoagulants. And we found out that all new oral anticoagulants, factor 10As, and direct thrombin inhibitors have a decreased risk of intracerebral hemorrhage compared to what? Coumadin and heparin. And nowadays, for all the drugs, we have all these new antidotes that are very, very expensive, but we also have FDA-approved antidotes for factor 10A inhibitors as well as direct thrombin inhibitors. Good, you guys are amazing. So what is the importance of anticoagulating, everyone? So the main thing of why all these new drugs came out, why did low molecular weight heparin come out, is because in the first 10 days after a DVT and PE, the chance of reoccurrence is the highest. And that's why when you give fixed dosing low molecular weight heparin or these new drugs where here you go, you're perfectly anticoagulated, it's what you want. Because when you use unfractionated or Coumadin, it's always hard to get the PTT where you want it to be. It's always hard to get the INR when you want it to be. And that's why these medications really took off. So what are the indications to anticoagulate? Proximal DVT, anything above the knee. Most cases of below the knee DVTs, you don't have to anticoagulate. It's from case by case. If you say the magic words PE for board exams, you are going to anticoagulate for a pulmonary embolism. And of course, you want to weigh the risk of bleeding, not because you're not going to anticoagulate, but you may do more consistent follow-up in these patients. So when we talk about treating, this slide over here is all about traditional therapy, heparin and Coumadin. So we always start heparin first. Heparin comes in two flavors, unfractionated, which is continuous drip, and low molecular weight. And the reason why we start heparin first is because Coumadin will always inhibit protein CNS, right? And you want to have that buffer before you actually start the Coumadin so you won't be in this super pro-clotting phase to get evil things like skin necrosis. And when we talk about the overlap of both, you just have to memorize it out, that the overlap between heparin and Coumadin is always going to be, you need to have 5 days minimum of what? Coumadin and heparin overlap, and when the INR is between what? 2 and 3. So even if the INR is between 2 and 3 after 1 day or 2 days, you still got to go a minimum of what? 5 days. So you just have to memorize it out that way. So what are the options for anticoagulation initially? Well, unfractionated, low molecular weight. Fondaparinux, which is an injectable factor 10A inhibitor. We don't use a lot of it. It goes by the brand name Estrixa. And of course, the oral factor 10As. Notice how I didn't put oral direct thrombin inhibitor, because the oral direct thrombin inhibitors only got FDA approval if you gave heparin first. You just can't give it by itself. So those are the only things that actually will be FDA approved for initial anticoagulation of someone with a PE or DVT. A bleeding risk, I stole this from the cardiologist, has bled. I'm sure many of you guys seen this for atrial fibrillation. We use this to see what the risk of bleeding when we anticoagulate for PEs and DVTs. This here is a summary of a lot of the evidence-based medicine of how they do endpoints for bleeding. Some we'll talk about minor bleeding, which you're pretty much not going to do anything about. You know what I mean? This is bruising and menorrhagia. But the big thing is always here, major bleeding. That's what many of the studies are about. Many studies define major bleeding as dropping your hemoglobin, needing a blood transfusion, or what we talked about today, which is bleeding into a vital organ. The two major organs are CNS and the GI. So on my following slide here, this is going to be the CNS, the question we just did, and I gave the bullet points, which is all the new direct oral anticoagulants have a decreased risk compared to warfarin. But in GI bleeding, it's a little bit different. So all the new direct oral anticoagulants, have an increased risk of bleeding compared to warfarin, except one, which is Eliquis, apixaban. Now, apixaban's not better, it's just the same. But when you look at these studies, they really clumped all the different studies together. And the bottom line point is there is truly, truly one new oral anticoagulant that really dragged the whole class down. Does anyone know what new oral anticoagulant really has the highest risk of GI bleeding? It's dabigatran. You guys call that what? Pradaxa. And why does it do that? It goes down to the pharmacologies, because for Pradaxa to get absorbed and work, you need an acidic pH in the stomach. And that's not good. Low pH in the stomach makes you predisposed to what? PUD and stuff like that, right? So it's really dabigatran that really dragged everyone down. So special populations. So when do I think about unfractionated heparin? Of course, renal failure. Don't use low molecular weight heparin in people with a very low GFR. If they're hemodynamically unstable in the ICU, definitely if I'm going to give a lytic, I use unfractionated. And then I would say that, the two things I would circle with your red pen would be malignancy and pregnancy. So there's clearly good data about low molecular weight heparin in malignancy. And in pregnancy, low molecular weight is also great. Secondary to tetragenicity, we do not use any type of warfarin. IVC filter, well, we'll keep it simple for the boards. If you can't anticoagulate for whatever reason, you put a what? IVC filter. If you're on appropriate anticoagulation and you deteriorate clinically, you put a what? IVC filter. They say they're retrievable, though I'm sure none of us has ever seen anyone take it out, but supposedly they are retrievable. And if you look at this PE over here, you guys all see the PE here, yes or no? Oh, humongous. It looks like a big saddle embolism. And the reason why I put this here is that though how big this PE is, when we talk about the terminology massive PE is not determined by the size of the clot. It's really determined by one thing, hemodynamic instability. And when you have hemodynamic instability, that's the only indication for giving lytics. And when we give lytics, we can do it one of two ways. We could give it systemically, or if you have interventional radiology available in your hospital, they could do direct catheter thrombolysis. They could actually, do mechanical thrombectomy, or they could take the lytic and really just push it right at the clot itself. So when we talk about mechanical thrombectomy, everyone, when do you offer that? Well, someone has a massive PE and you cannot give a lytic. If you can't give a lytic and they have a massive PE, then you have to surgically take it out, or like I said, if IR has ways of doing it, that would be indicated at that time. So I'm just showing a picture of someone who came in. Notice that this pulmonary embolism is not as robust as the one I showed previously, but patient was hemodynamically unstable. We pushed a systemic lytic, and look what happened. It busted the clot, so it worked out really well. Oh, how about this one, folks? Radiology calls you to say, hey, the CT scan reveals emboli in the right lower and middle segmental arteries. You begin the patient on low molecular weight heparin and Coumadin. The patient asks, hey, how long do they need to take the warfarin? You tell the patient, and I'm going to press the answer button. Here you go. What are you going to tell this patient? Yeah, so when I look at this, I always ask myself, class, is this the patient's first clot or second clot? You don't know. Was this clot from a reversible cause or a non-reversible cause? The answer is, we don't know. So that's the whole importance about deciding who gets lifelong anticoagulation or not, are going to be these things. So good job, everyone. A 44-year-old man is evaluated in follow-up for an episode of an unprovoked. That's the buzzword there, right, folks? It's unprovoked. Left proximal leg DVT 3 months ago. Following anticoagulation with low molecular weight heparin, he began treatment with Coumadin. INR testing done every 3 to 4 weeks has shown a stable therapeutic INR, and he has a mild left leg discomfort after a long day of standing, but it doesn't limit any of his activity. He tolerates Coumadin pretty well, family history is unremarkable, and he takes no other meds. On physical exam, vitals are normal, and he has some mild edema of the left leg below the knee with some post-thrombotic pigmentation. That's actually pretty common. The remainder of the exam is unremarkable. Okay, so which of the following is the most appropriate management in this 44-year-old person with an unprovoked clot? Take a look at those answer choices for me. Here we go. Oh, wow. Well, how about that? So this is where the art of medicine comes in. So when we talk about a clot, it's either going to be provoked or unprovoked, right? If it's a provoked clot, you guys are awesome. What are you going to do? Stop the bad habit. And how long do we anticoagulate for? 3 months. So that's easy. The bad part is when it's unprovoked, right? Because the guidelines don't really help us. If it's unprovoked, it's bookshelf between two recommendations. One would say, at minimum, patients at minimum need to be anticoagulated for how long? 3 months. And then on the other side of the bookshelf, because we don't know what caused it, what's the maximum you have to be anticoagulated for? Forever. So does that help us as internists? No, you have 3 months and you have what? Forever. So that's where my next couple of slides are going to help the internist and on board exams determine who gets a shot of stopping lifelong anticoagulation. And at this point, the answer is, yeah, pretty much forever. But what can we do to help maybe give them a trial off anticoagulation? Let's have a couple of questions. Number one, does aspirin prevent the recurrence of DVTs and PEs? Yes or no? The answer is yes. So when we talk about these aspirin slides, what does it mean? It means in people with unprovoked. If you're unprovoked and you want to actually get a shot of anticoagulation off of it, they did a study that showed that if these patients who weren't supposed to be on aspirin already decided to go on aspirin, the chance of reoccurring a clot that's unprovoked, it decreased by 20%. So what does this mean is that if you have a patient you want to think about stopping lifelong anticoag, you maybe could convince them that maybe you should just go on what? Aspirin. And that's what that showed. So, okay, all right. Now, what about this question? Does D-dimer predict the reoccurrence of an unprovoked DVT-PE? Yes or no? The answer is yes. So when we talk about D-dimers, you always wonder, why did that person order a D-dimer? You know what I mean? We know it's a clot, you know. It's to get that baseline right off the bat. Why? Because if you have an unprovoked clot, the patient comes to your office and says, hey, doc, can I get off anticoag? If you check the D-dimer at that point and it's still elevated, is that a patient you're going to take off anticoag? Probably not, right? But if they agree to go on aspirin and the D-dimer is low, maybe that would be a patient you would what? Consider. So that's where we use that. But then another study came out, and it's this question over here. Is gender a risk factor for the reoccurrence of an unprovoked DVT and PE? Yes or no? Yeah, gender plays a role. So let's ask this question to class for participation. Who says who's at the highest risk for reoccurrence? Who says it's going to be males? No one, right? Who says females? Wow. The answer is males. So, and I know why. I know why. You guys are thinking what? Estrogen. I know. So it's actually males. Don't worry, we deserve it, you know. So when we talk about, you know, this study, it now comes down to if someone has an unprovoked clot, there's only really one gender that has a shot of going off lifelong anticoagulation. And who's that? females. Okay? So I put some common clinical questions and exam questions. So people always ask me, hey, Dr. Raj, what about biliverdin? And what about argatroban? Now, remember biliverdin, that's what the cardiologist was talking about. If you have people with unstable angina and NSTEMI going to the cath lab, and you want an alternative to heparin and a 2B3 inhibitor, you could use what? Biliverdin. And that's what it's only meant for. It's not meant for PEDVT. It's very what? Short-acting. Argatroban, you're only going to use it in one patient, someone who has what? HIT. It's not; those drugs are not approved for what? Any of this PE or DVT type stuff. People always ask me, what lab should I use before starting a new oral anticoagulant? I always feel, you want to get kidney function because some of these drugs are not really good in people who have renal failure. And because PTTs are going to be all out of whack once you start them, I like to get a baseline to see where the patient is before starting these medications. And people always ask me, how do I transition to these new drugs? Well, if you're on a low molecular weight heparin, not a big deal. You just stop it. And when the next dose comes around for the low molecular weight heparin, you just start the medication. If it's going to be Coumadin, not a big deal. You just wait till the INR is below 2, and you start the med. So I just put these there. So let's talk about sleep medicine. This is not time to sleep. It's sleep medicine. So the only thing we're going to talk about today is OSA and a smidgen about central sleep apnea. So what does apnea mean? It means no flow. Flow of what? Air, no oxygen in, no carbon dioxide out. When we talk about the definition of sleep apnea on the first bullet point, it's practically no flow at all, greater than 90% decrease in the flow of the air. And how long does an apnea have to be when I score it during a sleep study? Almost 10 seconds. That's quite a bit. And we also have something called hypopneas. These are kind of like wannabe apneas, you know what I mean? So the airflow isn't going to be greater than 90% reduction. It'll be kind of like greater than 30, maybe greater than 50, depending upon the scoring rule I use. But they're also associated with some desaturations. And hypopneas are, like I said, they're wannabe apneas. They're not as bad as an apnea, but we use apneas and hypopneas together to come up with something called the AHI, the Apnea-Hypopnea Index, which we'll talk about when we talk about how severe someone's sleep apnea is. The bottom bullet point says rares. It's kind of glorified snoring. You don't meet the criteria for a hypopnea, and it's not traditionally factored in when we talk about the AHI, the Apnea-Hypopnea Index. So this slide is showing a really simple cartoon of what an obstructive apnea is. Notice how patients trying to breathe, effort, but no flow. If it lasts 10 seconds, it's an obstructive apnea. If you want to diagnose sleep apnea, everyone, piece of cake, order a sleep study. Nowadays, there are two main types. There's an in-lab study, which you call polysomnography, the Cadillac of studies. But I always laugh at a in-lab study because does anyone sleep during the in-lab study? No. And chances are you're probably going to do a home sleep study. Sure, there are certain rules when I do a in-lab. If you're hypoxic, if there's comorbidities, of course, in-lab. But, nowadays, home sleep studies are a real game changer. No one should go undiagnosed with obstructive sleep apnea. And let's be honest, everyone, who really decides who gets an in-lab study versus a home sleep study? Insurance. So when we talk about, severity, what does it mean? Notice down here that if you stop breathing 0 to 5 times per hour, it's normal. If you stop breathing 5 to 15 times per hour, it's mild sleep apnea. 15 to 30 is moderate. Anything above 30 is severe. And when we talk about sleep apnea, everyone, I think the rule of thumb is that where is the obstruction class? Is it here in the gut? No, it's where? Up here in the neck, right? So that's why many people you don't think have sleep apnea actually do have it because of their jaw, their tongue, their neck circumference, all these other things going together. You don't have to be obese to have obstructive sleep apnea. Many of you guys heard of this. It's called OHS, obesity hypoventilation syndrome. You don't necessarily need to have OSA with OHS. If you have both, that really stinks. But OHS means you're obese, elevated BMI. Hypoventilation means when I do an arterial blood gas, the CO2 is going to be elevated. So just based upon OHS, regardless if you have OSA or not, I'll give you bilevel, BiPAP. Why? Because it will actually blow off the what? CO2. And another name for OHS, people call that Pickwickian syndrome. How do you treat sleep apnea? I always chuckle when I hear this because no one does it. Weight loss, don't drink alcohol, avoid the Xanax, don't sleep on your back. Do these things first, okay? Then when you want to treat it, well, it's all about positive airway pressure. So remember, PAP therapy is not the mask. The patients get to choose the mask on the nasal pillow, nasal mask, full face. They get to pick it. But the big thing is giving this positive airway pressure to open up the upper airways. It causes a pneumatic splint. So the ones I've only seen on board exams are CPAP, continuous, I pick one pressure, or bilevel, which we use if you're CO2 retainer or if you don't tolerate CPAP. There are two pressures, an inspiratory pressure and expiratory pressure. But no one should be surprised. Not everyone tolerates PAP therapy. So there are other things. I'm actually a big fan of dental devices. I think that if you find the right dentist who knows what they're doing and works together, really good for mild sleep apnea, really good for maybe moderate, someone who doesn't have hypoxia. Provent, it's these little devices that you put on the nose right here that prevents you from breathing out through the nose, causes some pressure to back up, open the airway. We don't really use that, Surgery, sure, but surgery is surgery. We've come a long way when we do surgery. Many of my ENT doctors will do a sleep endoscopy, make you sleep and see where the collapse is before picking a procedure. Most patients have to fail CPAP. Some even have to fail CPAP and a dental device before doing surgery. And Inspire is the brand name. It's this little remote control down here, if you could see it. Has anyone seen that before, that remote control? It literally is the size of this right here. It's a tongue stimulating device where we actually will put a pacemaker in the right chest wall. One lead connects to the chest wall, the other connects to the hypoglossal nerve. And then literally, I'm oversimplifying it, when you go to bed at night, you turn it on, and every time you breathe, it stimulates your tongue to go forward. I know. So obviously, we use this for people who fail traditional therapies. If you say surgery, it usually is going to be, are you going to qualify for a tongue-stimulating device versus traditional surgery? So central sleep apnea means what? That there's no what? Effort. So central sleep apnea, no effort, so you have no what? Flow. That's what it is. And it lasts for 10 seconds, then we call it essential apnea. When we talk about central apneas, everyone, is that I just put them into two broad categories to help my thought process out. There are people with central sleep apnea who are hypercapnic in nature. So if you do a blood gas, the CO2 is going to be what? Elevated. And who are these people? Many people have these neuromuscular diseases. So I put some sad ones up there. ALS, which is Lou Gehrig's, myasthenia gravis, CIDP. Remember, no one really walks around with Guillain-Barré. That's the critical care diagnosis. Chronic Guillain-Barré is called what? CIDP, chronic inflammatory demyelinating polyneuritis. And the last thing that can cause central sleep apnea is what? Drugs. What's the classic drug? Opioids. Things like what? Methadone. We all love that mu receptor in the CNS, remember? So the other type of central sleep apnea you can get if you're not hypercapnic during the day, you could have a low CO2 level today, non-hypercapnic. And what is the big one I want you to circle like over here? See the third bullet point? It says what? Sheen-Stokes respiration. So when you went over cardiology, there are people with a really, really bad EF. They get the Sheen-Stokes respiration. And those are ones where the CO2 will be on the lower side. They will be on the lower side. So how do we treat sleep apnea? Central sleep apnea, everyone. Thank God it's rare to begin with, but you want to treat the underlying cause. So to treat the CHF, you treat the CHF. I mean, beta blockers, ACE inhibitors, things that reduce mortality, Lasix, and all these things. And then as far as treating the central apneas, that's tough. Because when you give CPAP and BiPAP, you're not really treating central nothing. You're just treating if there so happens to be some obstructives in there. Now, this bullet point down here, this is getting really detailed into sleep medicine, so I apologize. If you see something called ASV, which is called adaptive servoventilation, it's a type of machine, do not give it to anyone with CHF. There were studies that show it may actually increase mortality. We thought it would be the answer, but it's not. And the last thing I wanted to point out is, do you see over here on this slide, it says respicardia? I don't know where medicine's going nowadays, guys, but we like putting machinery in everyone. So for obstructive sleep apnea, we have that Inspire tongue stimulating. This right here is actually called Respicardia. It's a diaphragmatic pacer that we put into patients with central sleep apnea. Cardiologists love it. So if you are having central sleep apnea, you're symptomatic from it, and they want to treat the central sleep apnea, and this is only approved for those with Sheen-Stokes heart issues, they put in a Respicardia where the wire goes through one of the major veins, it innervates the phrenic nerve, and it stimulates the diaphragm. Really scary. And then there are also rare things out there that, thank God, we don't see it. I see it when I'm in Children's Hospital. Things like Odine's curse, which is otherwise known as congenital alveolar hypoventilation syndrome. Very sad with these patients. They lose their control of breathing, have central apnea. It's very, very, very bad. We're going to do critical care medicine, everyone. I want to talk about ARDS and shock, and we're going to be all set for today. So ARDS, everyone, is, how do you define ARDS? I put the classic way we define ARDS, which is the big three over here. Number one, it's a PF ratio. And what's a PF ratio? It's going to be where the PaO2 is going to be normally around 100 for me and you. The FaO2 is normally what? 21% if you're breathing room air. So if I were to take 100 divided by 0.2, the answer would be 500. So everyone's PF ratio in class should be around 500. But you can imagine that as your PaO2 goes down because you're hypoxic, or as they start giving you more oxygen because you're hypoxic, what happens to the value of the PF ratio? It gets lower and lower and lower. And that's why, in general sense, we see a PF ratio less than 200 usually defines what ARDS is going to be. The second bullet point is acute bilateral findings, so make sure they're not chronic. And the last thing, in the very, very traditional ARDS, we used to do a lot of these Swan-Ganz catheterizations, which we don't do anymore because it's invasive. So traditionally, you wanted to have a Swan reading that's very low because, let's be honest, class, what disease mimics ARDS, at least radiographically to a T? The answer is heart failure. And that's why, if you want to know if it's heart failure or not, in the olden days, that's when we did the Swan-Ganz catheter. But we have newer guidelines that I'll mention quickly. When we talk about ARDS, the question always becomes why, and I put them into two categories, direct and indirect causes. The most common direct cause of ARDS is always going to be aspiration, aspiration, aspiration. When we talk about indirect causes, I mean, sure, it could be pancreatitis and all these other things, but by far, the most common cause of an extrapulmonary etiology of ARDS is sepsis. So please, that's why when you have your patients with sepsis in the ICU, you're like, how did they get ARDS? It wasn't even a pulmonary issue. It's probably from the sepsis itself. But whether you call it direct or indirect, we treat them all the same on the ventilator. I just wanted to mention that. So this is one of the air quote newer definitions of ARDS in 2012. And the big thing here is, number one, you don't need to swan these patients all the time. They could actually, you could evaluate them with echo, which seems very practical, clinical, brain natriuretic peptide, all these things put together. And also, based upon these guidelines, you could start using terminology mild, moderate, or severe ARDS. And that really is based upon, well, how low is that PF ratio? The lower the PF ratio, the more severe the disease is going to be. So now the question becomes, how do I explain ARDS briefly so you could answer questions on the board exams? So what happens is, if you guys could look at my hand over here, this one hand is an alveoli. And what happens is that in the alveoli in ARDS, it collapses. So not only does it collapse, it gets filled with this inflammatory fluid. So if you look at this over here, this is a normal alveoli on this side, but on this side, notice how the alveoli is somewhat collapsed, and notice how it's filled with this inflammatory fluid. And we don't know what causes ARDS. We don't know, there's no prophylaxis for it, but everyone always asks me, where did this fluid come from? So it comes down really briefly to some basic physiology, because remember, in cardiogenic pulmonary edema, there's an increase in the hydrostatic pressure because the left ventricle is not really working. Blood backs up, and the pressure in the vessel pushes fluid into the interstitium, into the alveoli. And that's why the wedge is high. In ARDS, it's also known as non-cardiogenic. So where does the fluid come from is that the capillaries surrounding the alveoli become very friable, and all the proteins that should be in the capillary get sequestered into the interstitium. And what do proteins do? They're like sponges. It increases the oncotic pressure. So it draws fluid to them, and that's where the fluid goes where? into the alveoli. And that's where the fluid comes from. And that's why it's called non-cardiogenic pulmonary edema. So when we talk about ARDS, that this is a classic patient right here, right? Someone comes in, it looks like there's a right lower lobe consolidation over here. And anytime you have a pneumonia in the right lower lobe, how do they get it? They aspirate it. And then what happens a few days later, this is an ARDS type picture. So the first thing I notice over here is that this patient is what? Intubated. So on board exams, on any exam, we only manage ARDS when you're on the what? The ventilator. There's no role for non-invasive. You have to be vented. And then I look at the lung fields and I ask the question, what type of pulmonary disease is ARDS? Is it a heterogeneous pulmonary disease or a homogeneous? And the answer is heterogeneous, meaning that there's always going to be good lung and bad lung, right? Very few things are homogeneous. That means every lung is equally effective. So when I look at this looks like it's a little better aerated over here, not so much over here when we talk about ARDS. And why am I making a note of that is because when we treat ARDS on the ventilator, what lung are we really trying to save in ARDS? The good lung or the bad lung? The good lung. Who cares about the bad? It's already done. So everything we do is to save what we call the good lung that's left in ARDS. So if I were to just show this chest x-ray and nothing else and said, hey, does this patient have ARDS? The answer is, I don't know. Why? Is because what is this patient's PF ratio? You don't know. What was the patient's wedge pressure? You don't know. So I could play the game on the board exams and say, this is a patient that comes in, HIV positive, CD4 count less than 200. What's this? PCP. I can make this a patient who's quant gold positive, comes from India. What is this? Miliary TB. This could be a patient that comes in BNP of 2,000, EF of 15%. What is this? CHF. So remember, it could be anything. ARDS has to meet the criteria. So when we talk about ARDS, well, how do we treat it on the ventilator? We'll get to that in 1 second. Of course, first bullet point is treat the underlying cause, treat the sepsis. Medications, steroids, what a surprise, are always spicy. Do we give them? Do we not give them? So one of the classic studies show that if you give steroids 2 weeks after the ARDS, like a little later in the course, that's no good. That may increase the risk of death. But follow-up studies have shown that if you gave the steroids early in the course, well, maybe they'll reduce the mechanical ventilation. It reduces ICU length of stay. But the trick is you have to give it what? Early. And what's the most common cause of ARDS? Sepsis. Is that a good idea to give a lot of steroids to sepsis? Probably not, right? So it's tough. It really is tough. And the key thing about these studies is that you want to give the steroids early because ARDS definitely has stages. So stages are an exudative stage where there's still a lot of inflammation. Then if you don't do anything, it goes through a progression of the fibroproliferative stage, eventually to a fibrotic stage. And that's where things that help out inflammation will be more beneficial if you give it early in the course when you're still in this exudative stage. So now we're going to talk about ventilator management. So please circle the word ventilator management. So there really is only there's only 2 questions they're going to ask about ventilator management. Number 1, what is the only thing on the ventilator that has been shown to reduce mortality, prolonged survival in ARDS? Yeah, great yell out right there. Low tidal volumes, you know what I mean? And why do we give low tidal volumes? Is because what lung are we trying to save? The good lung or bad lung? The good lung. So you can imagine that if the bad lung is all, clotted off, for lack of a better term, that air volume, that tidal volume is not going to go there. It's all going to go where? To the good alveoli. If it gets all that tidal volume, what's going to happen to the alveoli? It's going to have like volutrauma, barotrauma. So we use low tidal volumes to protect the good alveoli. Now, I got to tell you, when you give low tidal volumes, is that comfortable for the patient? It's horrible. Imagine taking your tidal volume and cutting it right in half. That's what we're doing. Are there going to be consequences physiologically by giving low tidal volumes? Yes or no? Yes, it's horrible. But why do we do it? Is because it improves survival. And I gave you the physiology behind it, but also there's these trials. There's always studies, aren't there? It's called the ARDSNet trial. and they have something called the alveoli trial, where they randomize patients to big tidal volumes and low tidal volumes. And we do know it helps out survival. So we're willing to accept all the consequences of giving low tidal volumes just based on the fact that it improves survival. The next question they're going to ask you on the boards is, on the ventilator, what is the best way to oxygenate someone with ARDS? You guys are just amazing. It's PEEP. What does PEEP stand for? Positive end expiratory pressure. So what does it mean, PEEP? I mean, if you want to look at me, like, imagine a patient's breathing out through a tube. PEEP is like a valve that closes at the end of expiration. So imagine like, and when it closes, what happens to pressure? It backs up. And what's going to happen to these alveoli? They're going to what? Distend. So PEEP helps out with oxygenation. We're going to assume they're on 100% oxygen because they should be. So to help them out even further, we like to give them some PEEP. Now, can you just take the PEEP button and like crank it up as high as you want, as much as you want? No, that will cause barotrauma in itself. So there are things that we use to kind of figure out how much PEEP we give. We call those the peak and plateau pressures. And you definitely want to keep these peak and plateaus like less than 30 if possible, less than 30, 35. But yeah, I just want you to think we just can't crank up the PEEP as much as we want. And those are the only two questions. What reduces mortality on the vent? What's the best way to oxygenate on the vent? So, question, 63-year-old woman is admitted to the hospital for septic shock, secondary to community-acquired pneumonia. Antibiotics, fluids, pressors, her condition stabilizes. However, she subsequently develops ARDS and was intubated. Her O2 requirements increase until she's on the 100% O2. Vent settings are volume controlled, continuous mandatory ventilation, assist controlled for some of you who call it that. Respiratory rates 22 on the vent. Tidal volumes are 330, which it turns out to be 6 mLs per kilogram of her ideal body weight. FiO2 is 100. The PEEP is 5. A peak and plateau is 25 and 22 respectively. On exam, a febrile normotensive, tachy. Now she's breathing 15. Skin is cool. There's no JVD. Heart sounds are rapid, regular, but otherwise unremarkable. There's diffuse crackles are heard on pulmonary exam, but no edema. And they do an ABG as they should. pH is low. CO2 is high. PO2 is super duper low. Chest x-ray shows extensive patchy areas of opacification. Kind of probably that, good lung, bad lung, a heterogeneous type picture. Finally, here's the question. Wow. Which of the following is the most appropriate management of this patient? Look at the things they're offering you to do on this patient. And let's pick one. Dude, you guys are awesome. So, A, decrease the tidal volume. Wow, the patient's already on ARDSnet. I don't know how low you can go. Implement a prone positioning maneuver. I mean, I'm not saying don't do it. I don't think it's the next thing to do with this patient. Start inhaled nitric oxide. I mean, I'm not saying don't do it. I don't think it's the next thing to do. I wouldn't decrease the respiratory rate of these patients. Usually we keep it higher because of the low tidal volumes. But this patient's super duper hypoxic, and the PEEP is only at what? 5. And yet it's a normal peak and plateau. You probably could move up the PEEP a little bit. So yeah, you guys are just amazing. Okay, so this is one of those questions that you're not going to like me. It's hard, and this is the hardest it gets, and you'll see why I'm giving this question. So I preemptively apologize. The patient with ARDS is on the ventilator with the settings of 12 mLs per kilogram for the patient's tidal volume. This was switched to 6 mLs. This is based on that ARDSnet protocol. And why do we go from big tidal volumes to small tidal volumes? Because it improves what? Survival. What changes would you expect? And I'll let you think about it before you hit the button. Okay, I gave you a little time. Here we go. Let's button it up. All right. So when I get a question like this, and you could laugh at me, it doesn't bug me. What do I do on the boards? I just take a deep breath. And what I do is I enjoy the question, you know what I'm saying? So what is it asking? It's saying you're going from big tidal volumes to what? Low tidal volumes. So let's look at my hand. This is the alveoli thingy. So if I'm going from big tidal volumes to low tidal volumes, what's happening to my alveoli? Is it distending or is it collapsing? Collapsing. And what is the other medical word for collapsed alveoli? Atelectasis. Cool, man. And if you have atelectasis, does that make your lungs more compliant or less compliant? Less compliant. And if you have atelectasis, what happens to surface area? Does it go up or go down? Goes down. And if you have less surface area, what happens to the diffusion of oxygen? Decreases. Ta-da! So the answer is what? B. Cool. So when you do low tidal volumes, you know what I mean? What happens, did I tell you? Are there going to be consequences of giving low tidal volumes, yes or no? Yes. And you all agreed with me saying we do it because it improves what? Survival. So these are some of those consequences, you know? But, I'm kind of a nice guy. So do I like my patients with ARDS on the vent to have non-compliant lungs and be hypoxic, yes or no? No, I'm nice. I don't want this, dude. So what can I do on the ventilator to counteract the effects of the non-compliance and the hypoxia? PEEP. What does PEEP stand for? Positive and expiratory pressure. So as I give the PEEP, everyone, what's going to happen to the alveoli? It's going to what? Distend. And therefore, what happens to compliance? Improves. What happens to surface area? Increases. What happens to oxygenation? Improves. And that's why managing ARDS is a balance between low tidal volumes and PEEP. Ta-da! That's it. Someone's tearing up and crying. Don't cry. I feel bad. I hear the tears over here. You know what I mean? So when we talk about advanced ARDS management, I just wanted to mention these things because many of you folks hear about these things in the hospital. They're not going to ask this on board exams, but I want you to feel you got a very good lecture, So there's something called ECMO that surgeons love to do. It's kind of like dialysis of the lung. It's only saved in very, very severe cases, and you got to have CT surgery there. We do it sometimes, but it's very invasive. High-frequency jet ventilation, we don't use it anymore in adults. In kids, they definitely use it. One study showed it may increase in hospital mortality in adults. APRV is a form of ventilation where it's kind of like a glorified inverse ratio ventilation with a very long inspiratory time. We don't really use it because no mode of ventilation has ever been shown to improve survival or mortality in ARDS. Prone position and paralytics, I have a couple questions on those. So in paralytics, it's weird. It actually has one study that shows it improves what? Survival. So if you dose someone with paralytics up front, you get a good 90-day survival. Problem is, it's a paralytic, you know what I mean? And you do worry about critical illness, neuropathy, and myopathy. And the main thought process is that, well, many patients are bucking the vent. If you paralyze them, you could take over the ventilation in these patients. Question, does prone position ventilation decrease mortality in ARDS? I think this is a hand raiser. Class, who says prone position decreases mortality? Who says yes? You guys are awesome. It is yes. And so this is a journal article right here. And when you do prone position, literally in other countries, you literally just flip them on their stomach for better VQ matching. But of course, we have beds and technology here. That picture up there is called the rotoprone, where we flip them over. And we do use them if you use it early in ARDS, you know what I mean? Maybe before we do things like ECMO sometimes. But I'll tell you one thing, class. If you order a prone position bed in the ICU, who will hate you? The nurses. And like I said, there's no one setting of ARDS that has been proven better than another. We definitely give them 100%. We try to titrate up the PEEP as much as we can. We use low tidal volumes, and we titrate the PEEP to the peak and plateau pressures. And the key thing is the peak pressures, what does it mean to have a peak pressure? How much pressure does it take to get the air into the lung? What does the plateau mean? It's an end inspiratory pause. So at the end of inspiration, a valve closes to see how compliant or non-compliant the lung is. So what is the bottom line point, everyone? If you check a peak pressure and the peak is high, you have to check a what? Plateau. And the memorizing point is if you have a high peak and a low plateau pressure, the problem is resistance. Mucus plug in the tube, spasm in the lungs, biting the tube down. If the peak is high, you check a plateau and it's also high, now the problem is with what? Compliance. And that's where ARDS goes into, and that's why we use the peak and plateau pressures to titrate the PEEP. And now, for our last moments together, shock in the ICU. So, what is this? What hardware is in this patient? Does anyone see what hardware is in here? Any guesses? This is a Swan-Ganz catheter. So when we talk about evaluating patients with shock, of course, we do some hemodynamic monitoring. You know, there are invasive things we do that my pulmonary fellows love to do, A-line, central line, Swan-Ganz. But nowadays, we use a lot of non-invasive, and the big thing is always going to be the echo. Why do we want to monitor, have hemodynamic monitoring for shock? Is because we want to make sure all the organs in the body get what? Oxygen. We call that tissue perfusion. And tissue perfusion itself is made up of two concepts. One is, can you deliver the oxygen to the tissues itself? And the main part of oxygen delivery is always the heart. And that's where the cardiologist kicks in to make sure the heart's doing its job. Who carries the oxygen is my good friend hemoglobin, and these together are oxygen delivery. Oxygen consumption means, are the organs utilizing the oxygen? Can they extract it from the capillaries and use the oxygen? So I really love this chart. I made it for you folks. This is going to be the three main types of shock out there, shock, and here are the parameters, so we can go over them together. So when someone comes in and has hypovolemic shock from hemorrhage or just, volume loss from dehydration, what are the parameters I look at? What is the cardiac output? What is the wedge? What is systemic vascular resistance? And if I wanted to evaluate tissue perfusion, well, are they perfusing tissues or not? So in hypovolemic shock, you can imagine the cardiac output has to be low because no volume means no preload. Preload is part of what? Stroke volume. Stroke volume is part of what? Cardiac output. If you were to have a wedge, what would the pulmonary capillary wedge pressure be in hypovolemia? In hypovolemic shock, it has to be what? Low, because as you were told already, the pulmonary capillary wedge pressure is an indirect measurement of left ventricular end diastolic volume, which is another word for what? Preload. SVR is calculated, and you can imagine hypovolemic shock. What does your body want to do to SVR? It wants to what? Increase it. It wants to squeeze it. And when we talk about SVR, remember SVR is somewhat of the arteries, somewhat of the veins. It's a very ambiguous area. But remember, when you increase SVR, you'll always have more effect on the venous circulation. Why? Because the veins are more compliant than arteries. And what percent of total blood volume is in the venous circulation? 60 to 70%. So when you squeeze the venous circulation, you're taking all that blood and putting it back where? In the circulation. Good. So if you have hypovolemic shock, what happens to tissue perfusion? Well, if you have no oxygen delivery, what's going to happen to tissue perfusion? It's going to go what? Down. Cardiogenic shock, obviously the cardiac output would be low, probably from a massive MI. Blood is going to back up. The wedge is going to be high. And what will SVR be? Definitely it's going to be high because the fact that you want that venous blood to go back to the left atrium to increase that preload. And then what's going to happen to tissue perfusion? Well, if you have no oxygen delivery because of cardiac output, it has to be what? Low. And that's why the only way in the olden days to determine if it's going to be cardiogenic versus hypovolemic shock is that you had to do a what? Swan-Ganz. So take a red pen and circle these two over here. Then when you talk about distributive shock, I mean, they all are the same as far as the way they present hemodynamically, but the most common cause of shock in the world is always what? Septic. That's greater than 65% of all shock is going to be septic shock. And what's going to happen in cardiac output? It's initially going to what? Increase. But can the body keep up that increased cardiac output in septic shock? The answer is what? No. And that's why you need to treat the underlying cause. Why is the swan, why is the wedge low here? Is because in septic shock class, where is all the fluid? Is it in the vessel or the third space? Third space. So intravascularly, they're what? Deplete. So that's why it kind of looks like they're going to have a low preload, and that's why the wedge is going to be low, because all the volume is in the wrong place. And the telltale sign of a septic shock are these last two. SVR is going to be low. Trust me when I say it wants to be high, it needs to be high, but it can't do it. And that's why we have to give patients all these pressors like norepinephrine and everything like that. And tissue perfusion is going to be high. Why? Because of the fact that they're still having trouble delivering it, but the main thing is that the organs can't what? Consume the oxygen. And because they can't consume it, that's why the tissue perfusion is, as far as checking a central venous sat, which is this value up here, that's why it's going to be high, because of the fact that you're not consuming it, even though we're delivering it quite a bit. So delivery will be high, that's why perfusion's high, but we can't consume it. That's the main problem, is that we can't consume it. And a couple fun, and these ones are really fun, I mean it, practice questions. What is the diagnosis of a patient with the following hemodynamic profile on Swan-Ganz? So here is the cardiac output. I put the normal values right next to it. Here's the wedge. Here's the normal values. Here's SBR. Here's the normal values. So what do you think this is going to be? Yeah, and class, what was the telltale marker of hypovolemic shock of these parameters? The wedge, right? The wedge has to be what? Low, exactly. You guys are great. What about this one? 68-year-old male presents to the hospital with increasing shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, palpitations, history of CHF, bibasilar rails, hypotensive, BP is on the lower side. They do a swan, and here's the index, here's the wedge, and here's SVR. What's the diagnosis, everyone? I'm going to put the countdown. Yeah, and what is the telltale sign of cardiogenic versus hypovolemic? It's the what? The wedge. Same patient. What is the preferred drug of choice in this cardiogenic shock? Same patient. You know, I would say because it's cardiogenic, I really would gravitate more towards dobutamine. Why? Is because when you get that combo of a low cardiac output and a high wedge, you really need a what? Contractility agent. What is one reason why I would be scared to give a contractility agent in that patient in particular? The answer is the blood pressure, right? It was kind of what? Low. Because anytime you give dobutamine, or the other drug is what? Milrinone. Both of these are going to be contractility agents, but they drop the what? The blood pressure. So you want to be careful. So what do we do as clinicians? We may have a secondary pressor ready to go, but on a board question, this screams giving a contractility agent. The reason why we wouldn't use things that work on alpha-1 is because when you increase alpha-1, what happens to afterload? It increases. And do you want to do that in cardiogenic shock? Probably not, you know. Same patient, we haven't left him yet. What is, if I actually were to check the central venous sat, which is the amount of oxygen bound to hemoglobin right before going into the right atrium, that central venous sat is a marker of tissue perfusion. It just is. What do you think that central venous sat will be, high, low, or normal? Man, you guys are awesome when it comes to this shock stuff. That's great. So last one, second to last one, 71-year-old male is admitted for hypotension, tachypnea, tachycardia. Heart rate's 122, BP is low, respiratory rate's 28. They do a swan, and the cardiac output's high. The wedge is 8. SVR is 550, which is low. This is consistent with what? And I put this here to kind of end the lecture on talking about sepsis. So that's why I wanted that to be a nice transition over here. Yes, distributive shock secondary to sepsis based on what? The SVR being low. So number one class, sepsis is the most common cause of shock throughout. And people always ask me, how do you define sepsis? And the reason why I put this here is that we've moved away from some of the classic terminology you may have thought about. Remember things like SIRS, S-I-R-S, remember? Things like severe sepsis. We moved away from these things. We don't use them anymore. The new guidelines are going to be saying that we've done away with SIRS, systemic inflammatory response syndrome, and we did away with the word severe sepsis. Why? It's because I don't like that word. It makes it seem like there's severe sepsis and there's good sepsis. You know what I mean? All sepsis is what? Bad. So when you ask me what the definition of sepsis is, that the definition is a dysregulated host response to infection. That is the definition, like a Webster's definition. When you ask me how do we define it clinically, we use something called a SOFA score. And you can see over here in your notes, it says SOFA, Sepsis-Related Organ Failure Assessment. And there's values, numbers that we attach to this. And the 6 main organs we think about are things like the lung. We use that PF ratio like we did in ARDS. We think about the bone marrow, like low platelets. The brain, having a low Glasgow coma score. The liver, having an elevated bilirubin. The kidney, looking for urine output and serum creatinine. And of course, being hypotensive. And one of the major things that we see when we define septic shock is having an MAP that's low. So if you have a SOFA score of greater than 2, in this clinical setting of infection, we call it sepsis. When we talk about something called the QSOFA, this is a screening tool that the internist, the family practice doctor, my fellows, they use to see who's at risk of sepsis. It's a quick screening test called the QSOFA based on 3 criteria: altered mental status, respiratory rate greater than 22, and having a low blood pressure. This is how we screen for sepsis outside of the ICU. And now, if you want to use the word septic shock, there are 2 things that define septic shock. The MAP has to be less than 65 despite IV resuscitation, and the lactic acid has to be elevated. And that's why when you guys bill for sepsis when you round in the hospital, you can't bill for sepsis under Medicare and Medicaid unless you have an elevated what? Lactic acid. And that's why everyone's ordering lactic acid nowadays. So, last question. Which of the following approaches to the treatment of sepsis has been demonstrated to improve outcomes? Improve outcomes. Here we go. Last question. All right. So, the trick one was the blood transfusions. Don't get me wrong. We try to transfuse less, and less, not because it improves survival, because of the consequences and some of the things that happen when you transfuse too much. C and D, don't get me wrong. I mean, goal-directed therapy, everyone loves a protocol in everyone's hospital, but there were studies that show that it really doesn't change management. Now, E, I put that here for a very, very specific reason. There was no study that shows having a higher blood pressure greater than 80 to 85 will achieve anything, but I wrote down the word angiotensin II Giapreza. Who's heard of angiotensin II Giapreza? That's why I mentioned this. So the answer, of course, is going to be B, which is guessing correctly. It's all about treating broadly and de-escalating as much as possible. And one thing I'm passionate about is something called antibiotic stewardship. That means that we do start broad, but then we definitely want to de-escalate based upon cultures. And that's something that hopefully that that mentality is going to carry over. But what is Giapreza, everyone? I don't know if you realize this, is that there's a new pressor on the market. And why do I think this is important is because when someone comes in septic shock, what do I usually see with my fellows? They're on norepinephrine. If the blood pressure doesn't go well, they put them on what? Epinephrine. And my question is, how many catecholamine receptors do we have? They're already what? Saturated. And you're just going to have all the side effects. I'm not saying it's wrong to do it, but one thing I think about personally is that, if you're on escalating doses of norepi, I am a fan of vasopressin, even though it's non-titratable, because it works on those ADH receptors. And now, if they're still having low blood pressure, there is a drug out there which is pooled angiotensin 2. And angiotensin 2 class is a very potent vasoconstrictor. And also, when you actually have angiotensin 2, it eventually turns into what? Aldosterone. And what does aldosterone do to sodium? It makes you what? Reabsorb. And where salt goes, who follows? Water. Do you want that when you're hypovolemic? Yeah. I'm not saying put these patients on it. This is a super expensive drug. But I do believe that we need room for more pressors out there, and I'm very happy to have another weapon out there, something that's not going to be a catecholamine. Last but not least, class, did all you guys enjoy lecture today? Did you have fun? Did you? All right, I love you guys. I wish you all the best. If you want to get a hold of me, that's my website.